Good morning to everybody. First of all, I heartily congratulations to all the organization of the SASH for this wonderful workshop. I think this is really a great opportunity to present the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is the largest public health insurance schemes. I just share my presentations just for 2 minutes. As you know, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the largest public health insurance schemes. It's a very important, it's covered about 10.74 crores families, about the 50 crores population is already covers. The Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the annual coverage up to the 5 lakhs per family. And there will be no capping in the family size related to the age, genders, and other things. The important feature of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is totally caseless and paperless, and each and everything is on digital platforms. So, if you see the most, as you know, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is implemented in the 33 state and UTs, and more than 28,000 hospital is already impaneled in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and it's a 50% is the private and 50% is the government hospitals. And within the short periods, Ayushman Bharat Yojana gave the benefits of the more than 2 crores beneficiaries. Most of the states, because this Ayushman Bharat Pradhan Mantri Yojana is going for the universal health coverage in the futures. Most of the states is also covers the 100%, like the Ladakhs, Meghalaya, Jammu and Kashmir, and Uttarakhand. They also covers the remaining populations. And in futures, India is also go for the universal health coverage. This Yojana is started from September 2018 by the Honorable Prime Ministers. And as you know that within the short periods, it's reached up to the more than 2 crores treatments in the August 2021. So this is very transparent, and its main important is the digital platforms. Its important feature is the portability. If the Jammu Kashmir beneficiaries take the treatment in the Kerala also, and Kerala beneficiaries also take treatment in the Jammu Kashmir or Delhi, the impaneled hospitals. Each and everything is the digitally, like the beneficiaries coming to the hospitals. If he have the card, if he does not have the card, then the hospital identify the beneficiary, that name is there or not, then start the treatment. The pre-authorization is approved by the PPD, and then after the approvals, it's give the treatment, and after the treatment, give the discharge, and then claim requested by the hospital. And each and everything is online. With the specific period, there will be no manual intervention. Everything is on the digital platforms related to the pre-authorization, related to the treatment, related to the discharge summary, and related to the claims. As you know, the most of the hospitals, in the private and public hospital, the utilization packages, each and everything is online, like the general medicines, general surgery, ophthalmic, obstetrics. Most of the tertiary care packages, especially the cardiologists and orthopedics and urologists and neurology treatment is also taken during this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. You see the number of the beneficiaries continuously increased since the 2018 to 2020 and 21. Gender equity is very important things. After this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, previously we say the female is not going to the hospital due to the investigations and other things and expenditures. But after this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, you see the more than 50% or 50% of female is going to take the treatment in the hospitals. So it's the biggest benefits for, especially for the females. We have the health benefit package, which is continuously improvement after taking the feedback from the state. Also, we taking the feedback from the hospitals. Like previously, the health benefit package 1, after that the 2, and now it's the 2.2. And also we are give the incentive which hospital is give better qualities, like the NABH entry levels, NABH full accreditations. It's also give the incentive to the focus district, aspirational districts, hospitals, or metro city hospitals, and running PG and DNB hospitals, and some of the quality standards like the bronze quality certified hospitals. We give the incentive to the hospitals for the better quality healthcare services. And this incentive is cumulative. If your hospital is in the metro cities, full NABH accredited or DNVs, you get the 139% of incentives. So it's a very important feature that if any hospital give the better quality, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana give the better package rate for the hospitals. These are the some impanel criteria, like the hospital is minimum criteria. A hospital have the less than 10 bedded, but we also relax the empanelment criteria, especially in the focus districts, because Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the main target is the affordable and accessible of the health, the nearest healthcare, because in the golden hours, within the 1 hours, we want beneficiary go to the nearest hospital, and that's why we also relax the criteria of the empanelment, especially in the focused districts or the aspirational districts. Some of the direct impact portal is also there. Like we also monitor each and everything online, like the pre-authorization state, like the claim approval tests, and like the payment approval test. If you see the dashboard, each and everything is online, and pre-authorization is not approved within the 6 hours, then the force approval is there. So this is also very important that pre-authorization is important features for this benefits. Query trend rate, also we directly monitor the query related claims, and this is also very digitalized. So we are also specify the standardization of the document, and within the formats also, like the pre-authorization required documents, like the claim documents, and like the discharge summaries and other things. And we are also thinking for the each and everything is automated rather than the manuals. So the query rejections, TET formations, and other things like the rejection trend. If you see, the rejection trend is also very low down. Previously it's more than 9%, but now it's only the 1% rejection is there, because we have the standardization of all the documents. So the rejection rate is also very low downs. Our call center is also there. We take the each and every grievance within the timelines, and the 90%, 96% replies within the timelines is there. And we also have the fraudulent activities. It's the topmost zero tolerance culture is there. So, and we also now we start for the green channels. If any hospital which does not have any fraudulent activity and other grievances within the 6 months, we give the advance 50% payment if the claim is submitted. So we are also focus on the, because we know when the quality improvement, if you appreciate the hospitals, you improve the quality. If any hospital do the better services and better quality healthcare services, we give the advance like the green channels, 50% advance give when the treatment is done and the claim is submitted, so that the timelines for the payment is very reduced. With very artificial intelligence for the fraudulent activity, we have the world famous intelligence for the fraudulence. If any hospital give any fraudulent activities, we capture all these things. Medical audit is there through the desktop assessment and through the on-site assessment and through the other things. So the fraudulent activity is also very reduced in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. After that, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the main important is the National Digital Health Mission, which is really a very important and a very prominent features, especially in the digital health cares, the digital health IDs and digital hospital ID and digital doctors IDs is also there. Our policy makers, which is very helpful for the central government, state government, for the clinicians, for the laboratory and others, for the TPH and insurance, for the health apps, for the doctors and other practitioners, and for the non-profit organizations also and for the administrations, because each and everything on the digital platforms. If you see the part of the digital health mission, like the health ID, you create the health IDs, you create the digital doctor. If you have the doctors, you create the digi doctors IDs. If you have the hospitals, the health facility registry is there, the personal health record is also there, and telemedicine and e-pharmacy is there in the digital health missions. So thank you very much. And I think so the main incentives, special incentives in this Ayushman Bharat Pradhan Mantri General latest incentives is like the first is we are mainly focused on the payment, because we focus, if hospital give the treatment within the timelines, then this is the responsibility of the government that payment give within the timelines, and we are focused that payment given within the 7 days. Another important thing, if hospital give the better quality and there will be no fraudulent activity, then we give the advance payment also through the green channels. If hospitals submit the claim and then give immediately we give the 50% payments to the hospitals. Third important things, it's totally the it's a digital base. We each and everything is standardized through the pre-authorization, through the claim submitted, and through each and everything. So there will be no manual interventions. And we are also, the portability is very important. And the main goal of the Honorable Prime Minister is the affordable healthcare with the quality to the poorest of the poor. And we are also thinking for the universal health coverage to the people of India in near futures. And this is the main goal of our Honorable Prime Ministers, that how we give the better quality healthcare services to the India. Because after this COVID, we know that the situation is really a very improvement after this COVID situations. So thank you very much, and thanks to all such organizations to give this opportunity. Thank you very much.
Thank you very much, sir, for teaching us through the wider aspects of digital health. This session has been very interesting and very useful, especially for the young hospital administrators. Especially we got well educated with the National Digital Health Mission program. Thank you, sir, for sharing the knowledge on your specialized area. I'm sure everyone has something to as a takeaway. Now the session is open for discussion.
Thank you, Dr. Meena. That was truly outstanding. It has really changed the landscape of healthcare in India and will continue to be one of the major aspects of the administration.
Yes.
Any questions from our audience? Yes, sir.
At the outset, I thank you for giving a very excellent brief about the National Health Mission and digital mission as well. One question for the audience benefit, is there any scheme of assessing and accrediting on the bronze, silver or gold standard these organizations who want to go ahead with increased incentivization, as you said?
Yes, sir. Yes, sir. For the bronze, gold and silver quality certification, if your hospital is NABH full accredited, then go for the gold quality certification. If your hospital is NABH entry levels, then go for the silver quality certification. And if your hospital is not accredited, then go for the bronze quality certification. For the incentive for the bronze quality certification is the 5%. For the incentive for the gold or NABH full accreditation is the 15%. And incentive for the silver or NABH entry level is the 10%.
For wonderful elaboration of Ayushman Bharat. Just wanted to know, you have given the incentives at different levels for say accreditation, for DNB, for others. So are these additive or just only one incentive people will get? Suppose there is a medical college which is accredited NABH also and running PG seat. So is it, will it be 20%, 25% or will it be just 10%?
Yes, sir. The incentive is cumulative mode. If your hospital is in the metro city, then add the 10%. If your hospital in the metro city and the NABH full accreditation, then the 110 plus 15% means 126%. If your hospital is, the incentive is it's a cumulative mode. Like if your hospital in the metro cities full NABH accredited and DNB course, then you get 139% rather than 135%. Because the 10% of the metro cities, 15% of the NABH full accreditation, and 10% of the DNB. It's a cumulative. Like the basic is the 100, then 100 plus 10 is the 110, then 110 plus 15% above the 110, like 126 and then 126 and 10%, then 139. It's a cumulative mode. Okay.
Thank you for the clarification.
Yeah.
Any other questions from the audience? Yes, sir.
I just had one question. The packages usually tend to be fixed for a period of time, right? With regards to Ayushman Bharat, when is the next revision with regards to packages planned? Is it going to be on an annual basis or a 3-yearly basis? What is the plan for the packages? Like, for example, you have a package for CABG and it is decided as 1 lakh in
Yeah.
the base year being 2021. So when
Yeah.
is the next revision going to happen? Because the medical inflation anyway is between 10 to 15%. So how is it going to be factored in?
Yes, it's a very important questions. As you know, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the only the scheme where the revision of the package is continuously ongoing. If you see, we start in 2018, the HBP1. After that, HBP2, and now it's the HBP 2.2. So within 3 years, we revised 3 times. And now we are planning each and every year we revise this program health benefit package after taking the feedback from the hospitals also, and also taking the feedback from the states. So it's the revision is ongoing process.
Thank you, Dr. Meena. Any other questions from the audience?
Good morning, everyone. Working with Mahatma Jyotirba Phule, this
Yeah.
is Maharashtra. We
Yeah.
have come across a lot of difficulties in terms of information asymmetry, where the patient don't understand what question they are supposed to ask from the doctors or the administrators, and administrators also find it difficult to understand what kind of questions are and doubts the patients or relatives have. We have been working on this and the government's initiative have been already on it, but what are more initiatives to be taken in this regard so that we can work on this to minimize this? Thank you so much.
Yeah, in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana also have the call centers, like you big call to the grievance centers also, and we are also try to solve each and everything. Our ratio is the 96% call replies within the timelines and within the 10 minutes also. So I think so we have the proper grievance redressal systems also, and we are also our call centers call to each and every beneficiaries to take the feedback that what is the services is satisfactory or not, if any hospital take the payment or not. So the feedback mechanism is also there, anti-fraud activity is also there, in the world largest artificial intelligence is also there. So I think we will try.
Any other questions from the audience? Can we take questions from our online attendees? Thank you, Dr. Meena. That ends our question session. Thank you very much for your presentation. It was outstanding.
Thank you very much, and again congratulate to the all SASH organization for this wonderful workshop and give the opportunity. I really very sorry. I also want to come on site, but unable to come because of this situations. So, but again, I thanks to all and congratulations to the all team members. Thank you very much.
Very grateful for your presence here. And thank you.
Thank you very much.
Thank you so much, sir, for attending to the questions. On behalf of SASH 2021, we would like to present a memento as token of appreciation to our speaker, Dr. Jeetulal Meena, sir. Also, I would like to invite Dr. Pratapan Nair, sir, Senior Medical Administrator, Amrita Institute of Medical Sciences, Kochi, to present the memento to Dr. Prem Nair, sir, and Dr. Paramhans Mishra, sir. Thank you, sir. Thank you for chairing the session.
Now, we would like to welcome our next speaker for the day, Dr. Sandeep Reddy, to convey his talk on bridging the technology, a divide in healthcare leadership for digital transformation. Sir has a background in health service management, medical informatics, public health, and medicine. He has in past focused on teaching and research in healthcare management and public health. He is now researching and teaching the application of artificial intelligence in healthcare evaluation of health technology and hospital management. Our chairs for this session are Dr. Ashish K. Gupta, Director Program AHA, and Brigadier Dr. Ajoy Menon, who is a cardiothoracic surgeon at Armed Forces and has performed more than 3,000 surgeries over past 30 years. He has commanded the hospital for over 5 years. Currently, he is the medical superintendent at AIIMS and professor in faculty. May I now request the chairs to please come on the dais and chair this session.
Amitabh, to start with your presentation, and please maintain the time, and we will have question answer session towards the end, sir. We can continue.
Thank you. Before I get to the presentation, I would like to thank Amrita Institute of Medical Sciences, Academy of Hospital Administration, and the organizers of SASH 2021 for inviting me. It's quite a delight to be here. And the topic I would like to focus on today is bridging the digital divide in healthcare. And the outline for today's presentation is, firstly, we talk about the digital coverage across the world and even India, and then we'll focus on digital divide. What do we mean by digital divide and why is it important? And then further to that, we will talk about solutions. It's not just good enough to just focus on the problems. We also need to consider and explore the solutions. Now, when we look at the digital coverage across the world, it's indeed a marvel. And in fact, some people actually comment it is a 21st century success story, especially in mobile phone coverage. 85% of the world now live in areas covered by 4G. And also we're seeing newer and advanced form of technologies coming into play like 5G. And even in India, the staggering number of people who now have access to internet and are unique mobile users and active mobile social users. So you can see that there's increasing mobile coverage and increasing digital coverage across the world. And within that kind of digitization of various sectors, there's also digitization and automation of many aspects of healthcare. And that's where digital health comes into play. So what is digital health? According to the World Health Organization, it's the field of knowledge and practice associated with the development and use of digital technologies to improve health. And we have, amongst the audience, amongst the participants, seen the benefits of digital health and the various technologies employed within that spectrum, including telehealth, mobile health applications, wearable technologies, artificial intelligence, and so forth. And also we've seen various tailored systems like electronic health records, personal health records coming into play, including in the Indian healthcare system. And with the recent emergence of the pandemic, there's also been proliferation of various mobile applications, various digital health applications. While it's a sad situation with the pandemic and with the associated mortality and the morbidity, but also there's been glimmer of hope in the exploration of various digital health application, especially in the area of telehealth. I don't need to convince the participants about telehealth. Earlier, the esteemed speakers and the panel members talked about how digitization of healthcare is happening in the Indian healthcare system, but also the benefits arising out of it. But just to kind of emphasize the benefits here, we know with telehealth, it allows for reduction of barriers to access to clinical care. It augments existing clinical care, but also improves medication adherence and follow-up visits. And with mobile health, similarly, it also helps with self-management of chronic conditions, medication adherence, and also improves follow-up. So we do know about the benefits of digital health, but that's not the focus of this presentation. Rather, we are going to be talking about digital divide, which is increasingly becoming a major issue. We know that while there is increasing mobile coverage and increasing access to internet, still about 45% of people are, and in a significant amount of people in the least developed countries or developing countries are still not having access to internet. And 4G or newer wireless systems like 5G are still out of reach for many parts of the world, which rely on much more considerable slower systems like 3G or even old kind of LTE networks. So significant pockets of the population miss out on the connectivity even more. Now, let's define digital divide. The digital divide is the chasm between those who have access to technologies and the digital literacy to work them, and those who do not. To kind of explore that a bit further, it's those who are having access to digital technology and those who have not. And even with those who have access to digital technology, it's about whether they can use the digital technology. That also leads to the digital divide. Now, how does the digital divide happen? And largely it happens because of the social determinants of health. Those people who are already in low socioeconomic status, who have poor literacy, who live in rural and remote areas are likely to more suffer from the digital divide more than the people who live in urban areas and who have access to digital technology or who have the literacy skills to actually utilize digital technology. And further to that, there's also issues in terms of lack of access to particular kinds of technology like insufficient broadband, and it also kind of accentuates in the case of disabled and people who use low-performing devices. And this is backed by evidence and statistics. We see that especially the economically vulnerable have less access to internet compared to those who have who are in the higher economic status or high income categories. And also within a country, you can have variation in terms of digital access. For example, Kerala would have higher digital access compared to residents in Chhattisgarh. And also we have people who have access to mobile phones, but may not have access to the internet or to the computation technologies. Now, who gets impacted by the digital divide? The first group of people who come to mind are the older generation who may, because have not grown up with digital technology, as opposed to the younger generation, they are likely to be most affected, but also low income, as we earlier alluded to, but also people of female gender are known to have a correlation with the digital divide. Now, again, this is again backed by evidence, as you can see in the statistics, that women especially in the rural areas have lesser access to the internet compared to those who compared to the people of male gender and to those who live in the urban area. And now it's come to a point where increasingly organizations, multinational institutions have really recognize the impact of digital divide. In fact, the United Nations Secretary General has made the statement, which I'll read out now. The digital divide is now a matter of life and death for people who are unable to access essential healthcare information. It's so threatening to become the new face of inequality, reinforcing the social and economic disadvantages suffered by women and girls, people with disabilities and minorities of all kinds. That's a pretty strong statement coming out there about the impact of digital divide. And further to that, other stakeholders also talked about how digitization can be a luxury of the high income end of the population. I'll read out the statement from Sulakshana Nandi, who is the National Joint Convener of the People's Health Movement of India, who says, digitization adds a thick layer of exclusion. It benefits only the privileged, educated, and urban population. Again, a very strong statement coming from an important stakeholder here. Now, we kind of focused on the digital coverage, the digital divide, and the impact of digital divide, and even the causative factors for the digital divide. Now let's explore a couple of solutions. By no means this is a comprehensive coverage of all the issues pertaining to digital divide and all the solutions that can be used to address them, but I'll highlight a couple of important points. First thing we got to remember, within the digital divide context or within the digital health context, it's really important to keep the vulnerable populations in mind. We earlier talked about older generation, people of women gender, female gender, and also people of low income status. Likewise, when you employ digital health solutions, you would need to plan for and consider this kind of vulnerable populations. It's really important. But also keep in mind, it's just because certain segments of population who may not have the access to digital technology, or that's just not enough. You also need to take into account about how you would be able to educate them about use of digital technology. And we'll talk about that a bit later. Now, many times, people who do not take into consideration the vulnerable populations or the wider anthropological and the socio-cultural milieu of the target populations may implement technology that may not serve the purpose. We know in India, a large significant population use smartphones, mobile phones, as opposed to having computers at home. So why not utilize smartphones as the medium to deliver digital health applications or digital health programs? And with using that digital smartphones, you can also leverage upon the features of smartphones, like using text messages rather than utilize internet computer-based technology or internet-based images. Just use SMSs, ordinary SMSs, which most people have access to. And the other thing that we need to remember is it's not always the people who implement the solutions or the stakeholders like the governments and the healthcare institutions that have an answer. Patients also may have an answer. So it's important to consult with the target population while implementing any digital health solution. And exploring that further, kind of tailoring and customizing the digital health solutions according to the patient's needs. We talked about how it's much more preferable, especially in the developing country context and the rural and remote context, to use smartphones as opposed to computers or other kind of advanced technology. So leveraging on that, you can also use two-way text messagings, which allow for triaging of various conditions and early detection of many medical conditions. And further to that, you can also convert PDF kind of documents or paper documents into JPEG kind of formats, which means that you can message them to the patients, and they can use that to learn more about the conditions, or also know what is the treatment and the prognostic pathway in relation to their particular medical conditions. And also, it's important to remember the education level of your patients, and according to that, tailor your messages and make sure that they understand what you're communicating as a clinician or as a healthcare provider. And sometimes you may even want to use picture-based messages, like using of emojis and symbols rather than just text-based messages. We also need to encourage people and institutions to further e-health research, explore the various factors that lead to digital divide, the solutions that may lead to digital divide in the healthcare context. And also, there's quite a few institutions that have already undertaken research in this area that we need to consider those kind of solutions that would help in addressing the digital divide. I'll showcase a couple of examples in terms of research and successful stories that have bridged the digital divide shortly. It's not just enough to target the vulnerable populations in terms of digital health applications. It's also important to consider the healthcare professionals or the people who deliver the digital health solutions. Sometimes you may have to educate the healthcare professionals in healthcare IT, healthcare information technology, or the different varied different types of emerging technologies that are arising, like artificial intelligence, quantum computing, and so forth. So it's also necessary for the people who implement the digital health programs to be aware of what they're using. And not just the people who are there in the ground or people who are already working as clinicians, but also medical students, nursing students. They also need to be trained in this healthcare information technology, which is rapidly becoming an important part of the landscape. Further to that, going back to the earlier discussion about the context of social determinants and how varying groups of people, especially the ones who come from a very vulnerable status like low income status, people with existing low literacy or health conditions are much more likely to have face the digital divide as opposed to those who are living in urban areas and who have a high literacy and access to digital technology. So those kind of things have to be considered. It's really important to consider the aspect of human partnership in this digital rollout. It's not just enough to have a completely altogether pure kind of digital process. There has to be some sort of ability for humans to be involved and consulted during, not just during the implementation process, way before that, even in the planning process. Otherwise, we may be implementing a very technologically rich solution, but very, very culturally poor, or very, from an implementation point of view, a very weak solution. Now let's look at a couple of examples. In 2016, there was a study that was published in terms of the use of e-health kiosks in rural India. The study basically analyzed data over 7 years, considering the 10 villages where the e-health kiosks were executed, and they particularly focused on the infant mortality, which continues to be an issue, sadly, in rural areas in India. What they found was that where the e-health kiosks were implemented and had humans manning the booth, and they were able to guide women and particular target populations in terms of navigating the e-health kiosk related features, including access health related information. They found there was improvement in the health status of the health literacy, obviously of the target population, but also reduction of infant mortality rate. They compared it to neighboring villages where the e-health kiosk wasn't installed, and they found that there wasn't a decrease in the newborn child mortality as opposed to the villages where the e-health kiosk. So this is a very, very wonderful example of how you just do not implement the digital technology, but also bring the human element into play and be able to support patients' literacy. So this is really, really a good example. For those who are really interested in this study, I'm very happy to be contacted, where I can forward the link to the complete study. Another example that some of you may be aware of is the Reducing Maternal and Newborn Deaths program, where they not only utilize the digital part, but they also use the human element part, but more importantly, the human management processes like change management, bringing together various implementation process, including regular meetings and enhancing the skills of the ASHA professionals, but also utilizing technology for data capture and reporting. This has been implemented in Uttar Pradesh, and in fact, they've seen multiple benefits, including the prevention of about 16.4% of maternal related deaths and 5.2% infant related deaths over a 10-year period in Uttar Pradesh. Now, kind of coming towards the end of the presentation, we know that there is benefits with digital technology and the digitization of healthcare, and there's been multiple benefits that have been even seen in the pandemic period, like telehealth that has improved medication adherence, reduced the barriers to access to clinical care. But it's really important to also consider the vulnerable populations. Otherwise, we are really, really going to be creating much more health disparities by the rollout of digital technologies. In summation, to reiterate the points I made earlier, global mobile coverage is expanding. The digitization of healthcare provides a lot of benefit, but we need to be aware that the significant parts of the world that do not have access to mobile phones and internet, and this leads to the digital divide. Unless we consider the digital divide, we are going to be leading to significant disparities. With that, I end my presentation, and thank you for your patience in listening to me.
Thank you, sir, for this enlightening session. The point where you talked about e-health digital applications, and digital divide, and the solutions for bridging this divide was really informative. And I'm pretty sure that the precious knowledge Sir gave will definitely help us in our careers ahead. Once again, thank you so much, sir. Now the session is open for discussion.
Thank you, Dr. Sandeep Reddy. You have crystallized eloquently the efforts required to bridge the technology divide and demystify the process of digitalization, as it were. And one addresses the vacuum, the white elephant in the room, and that is the vacuum caused within the leadership, a generational shift within the leadership or the people who are at the forefront because of their inability to perceive the concept of digitalization. That is another aspect. But clearly, there are a lot of social, economic, and ethical considerations, and we have a long way to go. You can modernize equipment, but you can't modernize mind, and it takes time. Now I hand over to Dr. A.K. Gupta, who is with me, and he shall take the forum before asking questions.
Thank you, Dr. Sandeep Reddy, for putting the point straightforward. One major question I would like to ask you: how in a geographical area where the literacy rate is low, illiteracy can be increased, because they are, I think, interdependent.
Yeah, it's a very, very good question. In fact, that is why I refer to the social determinants, and any digital technology or digital health implementation has to consider the social determinants. So even in places where there may be high literacy, there may be other issues that are kind of having impact, and that could also lead to reduced access or reduced use of the digital technology. But going back to your specific aspect as to how we could address that literacy, I think one of the things I probably didn't mention very clearly, any digital technology or digitization of the processes have to consider, it has to be a multi-sectoral kind of collaboration, where you not only have the healthcare institutions or healthcare organizations, but other institutions which are responsible for literacy, for improvement in transport, improvement in housing, that had to be considered. And I think it takes some time, but in the end, the solution is much more sustainable rather than rushing into a solution which may not get used and becomes unviable. So that, it has to be a multi-sectoral approach in terms of those kind of situations.
Thank you. Any questions from the audience or from those who are on the virtual mode? Any question from the virtual mode? Participants, are there? No. Somebody raised hand? Here? Okay. So if there are no questions, I may, try to sum up what you have. I think the take-home message of your presentation is, considering that there is a rural-urban divide or regional disparity, or literacy rate, or maybe the gender divide also, as you say, access to technology, internet in men and women may be different, or even age-wise, like elderly, still bridging this digital divide. I think what is the take-home message is that we should, try to keep the vulnerable population in focus when we are planning any digital type of healthcare. And the technology to use should be simple, reliable, affordable, and cheaper in cost, can have good penetration. We should also consider training these people in use of technology by some way. And intersectoral approach, you have just said, is what is the way ahead. Then using smartphones and mobile phones instead of the laptop computers, cheap mobile phones with easy access, one-touch technique we can use. We must also try to look at how the people want to communicate with the provider rather than the provider deciding what to give to them. I think that is what we call is what is demanded should be given, not what is we create should be pushed. That should be the way we had. And send less documents to the person, only give a summary, give them in a picture or PDF form, easy to read without any distortion happening, give them in the local language, not the standard language. Picture-based will be, and most importantly, in the end, you say you also have to look at the professionals who are going to deliver these services. They must be oriented towards the need of the community and try to prepare and provide what is needed rather than what they think is good for them. With these words, I hand over to you, sir. You want to speak something? Anybody? Yes, sir. Dr. Nair is going to be there.
Please give a mic.
I was just curious because I'm just wondering whether the digital divide really divides it really divides the young from the old rather than from two economic groups. It is truly amazing to see how very quickly even the illiterate or the minimally educated individuals pick up on the digital smartphones, so that divide seems to be a different kind of divide from the economic divide.
Thank you, sir. This is exactly what I was also mentioning in my summation, in that the divide which we perceive is a generational divide. I call it the degeneration gap, because there is a huge a perceived difference in the way digital equipment is handled by a child and the same equipment is handled by his grandfather. And this is reflective in every aspect of our living. So probably this rural-urban divide is already there. That's an infrastructural and economic and fiscal aspect or a social aspect. Whereas there is this other aspect which is more important, an old timer who's trying to keep up with the technological advance within a hospital. So that's equally another aspect of the divide. Just saying.
Yeah, thanks for the feedback and comments. I agree with that.
Thank you, Dr. Sandeep. This brings to the end of this session. Over to you.
On behalf of SASH 2021, we would like to present a memento as a token of gratitude to our speaker, Dr. Sandeep Reddy. Now may I request Dr. Prem Nair sir to present mementos to our chairpersons for this session. Thank you, sir.
Now, let me welcome Ms. Shrabhani Basu, business strategist and management consultant, to deliver a talk on healthcare human resource today, the digital affirmation. And I request Colonel Dr. Vishal Mawa sir, Principal, Amrita School of Medicine, Cochin, and Dr. Dilip Kamath sir, Senior Medical Administrator, Amrita Hospital, Cochin, to chair this session.
Morning, everyone. Today, we now have Ms. Shrabhani Basu. She'll be speaking on healthcare human resources today, the digital affirmation. She is a very accomplished professional. She has been the recipient of the Best Women Visionary for Healthcare Award in 2019 from Medversity Apollo Group. So without, wasting any time, I'll request ma'am to begin her deliberations.
Good morning, all of you. Am I audible?
Yes, ma'am.
Yeah. So thank you very much for the invite. And I've been on this session, extremely important topic, and quite a few important aspects of my discussion have already been covered. However, without much ado, I'd like to just progress. It's a very short presentation, just for the ease of understanding a guided approach to what I'm going to talk about, and then we can take questions. Special thanks to Sandeep Reddy. Sandeep, your presentation has covered possibly a large part of my deliberations. Thank you so much, and I'll continue from there. I've shared a presentation. Would somebody want to screen that? So it is very honestly to an HR person who's I've been into HR, qualified in HR, but moved along with HR in a huge array of responsibilities, including operations, quality, marketing, branding, corporate communications, and quality and customer service, patient service excellence. So my presentation would include all of this together, and I term it as the digital affirmation. To me, the next slide, please. To me, there is an immense need. The challenge today is there has been immense amount of change in demographics and dynamics of our society, which is affecting the healthcare system. Sandeep just mentioned the degeneration gap, which I'm trying to intensify. It is a constant war for talents in healthcare. Now, with the current COVID pandemic and its continuity in various forms, the present work is analyzing the potential of digitalization for human resource management in hospitals. There is no looking back that without a proper digital framework as the major framework, as a skeleton for HR in healthcare, things will be very difficult to handle. Very, very difficult to handle. So that establishes the need, and how I will discuss in my forthcoming slides, please. The next one, please. See, we are constantly talking. Whenever I talk to, I've been here now for many, many years, multiple decades now. Whenever I talk to anybody, young, middle-aged, old, has been there, done there, successful, unsuccessful, I always hear that HR is all about attracting and retaining the best for the best human touch in hospitals. I sincerely hope we all agree. In case we don't, we can always take it up for discussion later on. Now, earlier we said that we need to attract and retain the best talent only. No, we also need to attract and retain the best, as in the most important patients, or everybody who needs care, the patients, the patient parties, the vendors, everyone. HR needs to attract all of them through its processes. I mean, I do understand that there is a marketing department which says we will do this. I do understand there is a customer service department which says we will do this. I do understand that there is a medical department of doctors who say we get our patients. But who enables them? It is HR which is enabling them all the time. I never say that HR is in the forefront of everything, but HR is the most important enabler, because there's not a single process in a hospital which is devoid of people. People will have to be there. People are the center of our focus, whether it's employees, whether it's patients, whether it's vendors, whether it's patient parties, whether it's the visitors who come to the hospital to just do some medical shopping. People are most important. Hence, digitization is the most important tool for us today. We have to increase the efficiency of every HRM process. I cannot go so much in detail because of the ease of presentation and limitation of time, but I'm sure you all understand. We have to attract the best talent. It has to be a very, very penetrative reach, just by word of mouth or just by advertising over the job site or a website or over a LinkedIn or over a Facebook. It's not sufficient today. There has to be a lot of penetrative search. There are a lot of important ways that we have to look for talent, and we are doing it. We need to improve the retention for staff, patients, quality. We have to generate repeat business. And I don't say generating repeat business means you've broken one hand today, please come with the other hand broken tomorrow. No, but the word of mouth that goes that this hospital or this bunch of people who are handling care bundles are very, very good at their work. Now this spreads, and then people start coming, and that's what we call all about medical tourism today. Increased communication channels. The biggest clog in a healthcare system today is communication at the right doses, at the right levels, to the right people. This is largely supported by a digital approach. Success directly linked to knowledge, skills, and commitment of employees. And how do you measure that? How do you gauge that? How do you see the trends? How do you measure how do you do the analysis if you don't have a digital framework? It is very, very important we have this. This slide is, to me, all the time the most important slide that I have on my desktop. I keep looking at it all the time that I'm working, because this is what keeps me going in all the work that we do. Next slide, please. There must have digitalization areas like continuous evaluation and support of recruitment, staffing, and marketing efforts with brand building. I moved into marketing and brand building. I don't say I'm an expert, but it came very organically to me, because we realized that at the end of the day, the marketing of any healthcare delivery system, whether it's a hospital or a small unit, clinic, polyclinic, whoever, or even a bunch of people who are trying to make a difference in healthcare, comes through the quality of the positivity of the positive perception people have about you, about your services, about your excellence, about your continuous reach, about your CRM levels. And that's how marketing and branding came. So there has to be a continuous evaluation and support. What are we doing? How are we doing? What is going right? What is going wrong? What should we do? What should we not do? All this is based on data. It's very important. Transparency, enrichment of employees' development and measurement of training efficacy on ground. Well, I'm a trainer. I coach, mentor from beginning from the, as I keep saying, from the doorman to the C-suite levels. I have no inhibitions. I do never say I'm a coach only for C-suite, because I cannot be a coach for leaders if I do not know the sentiments of the ground level staff and their requirements. So I do a lot of coaching and mentoring. Now I've realized that you have to be very good in understanding the the gap analysis, but even more important, of measuring efficacy of every training, coaching, mentoring program on ground. There's no point of doing anything to just mark a check in the tick box, a tick in the check box, sorry. It's very important that you link your efficacy, the root cause analysis, efficacy on ground. This is the whole journey of a training coaching program. And to me, the data and digitization and the tools are very important. Otherwise, it's very difficult for me to do. Now, approaches to, so I think we skipped. So we'll go to the core challenge. And the last, of course, is most important. Please understand, staff costs are the highest cost component in healthcare globally today. Who would not agree? Anybody sitting here? Anywhere between 47 to, I've seen about 82% of the total cost being manpower cost. So cost and staff optimization and processual improvement is very important. And how can you do this without data? How can you do it without digitization? It has to be extremely important and readily accessible and retrievable at any given point in time. The next one, please. So integrating new HRM healthcare technologies. I've spoken about co-challenges, and the trick, the fun is when you convert every challenge into an opportunity for work, right? So let's look at it from both the sides. So Sandeep was mentioning something about, and Sandeep, and then I thought I heard Dr. Nair speak on something about where is the actual challenge, whether it's the mindset between old and new, or the generation gap. So digital affinity of the HR staff, physicians, surgeons with regard to personnel recruiting. See, the whole challenge is about the generation mix and attitudinal landscape. I personally believe, and I always talk about it and I push this through, is if the lady who comes to work in my house, if she can use a Facebook, if she can use YouTube, if she can use, I mean, she's also using Amazon now, Flipkart now. So why can't we cash on this and say, okay, everybody has to be digitally included in the system? So I don't think, of course, there is a generation gap, and truly so that the grandson and the grandfather are on different landscapes digitally. But I do understand that if we could make efforts in turning this around, this solves a lot of problems. Digital support in everyday work for surgical, non-surgical departments. I'm sure there are a lot of doctors here, and very, very important for, I've learned whatever I have learned on the digital piece in healthcare HR from doctors. Approaches to digitally supported technical teaching methods. See, today is a big example. We are all connected. Had we not done this, we would not even have been connected and would have been waiting with a question mark. When can we next meet? I have been missing a lot of conferences and seminars during the pandemic because I thought, when will we come to an end of this? When do I come back to a situation where I go back to Amrita, or I go back to Father Muller's, or I go back to the IMA for a conference? So if we could do this, we could do much more. Digital frameworks in patient and patient party management. This is something which is constantly ignored. We talk about it, but how many people are actually working on it? Communication to patient parties, feedback to patients and patient parties, follow-ups with patients and patient parties. How many are actually doing it? Very few. So digital frameworks are very important. Measurement of success, I always believe there has to be a measure of whatever you do. Right, wrong, ambiguous, dexterous, whatever, but let there be a measurement framework. It can be constantly improved, which is directly linked to knowledge, skills, and commitment of the employees. This is most important. Having a process is just about 40% of the job done. Commitment to a process for efficacy on ground is most important. That has to be measured, and going digital is a great framework for support. Next one, please. That's the most important slide. So I have made a very brief presentation for the ease of timekeeping, and I'm more interested in any questions that are coming from the house. We can go back to the previous slide. I think there will be questions on this. So, and if you have, please let me know if you have any more questions or whatever. I'm open to the house.
Thank you, ma'am, for the wonderful presentation. So one of the points that you have mentioned is on HRM, right? So majority of the participants in this event are students. So could you just throw a brief light on difference between HRIS, HRM, and HCM? So these terms are always used interchangeably. So
The last one I did not hear.
HCM, Human Capital Management.
Okay.
Yes.
Very interesting question. Very interesting question. And my one line, I don't believe in advising, but my one line suggestion to all my fellow colleagues who are gearing up to become healthcare HR professionals, don't get seeped into the jargon mix. Let me tell you, just don't get seeped. I too am a visiting faculty and a management coach in a couple of business schools. And this question is a perpetual question that comes up. Let me tell you, I'll just take 1 minute for this. What did we talk about say 30 years back? We spoke about personal management. Yes? How many of us talk about personal management today? None. We spoke about industrial relations. How many of us do we speak of industrial relations today? None. Then we were, when I was in the mid segment of my career, in the middle of my career, people told me we need to have a lot of manpower. There is a manpower crunch. Please note the words, manpower, right? We slowly evolved to, no, we need to have manpower is just not head count. We need to go to, we need a talent pool. So manpower had qualified into talent, right? Those who perform. And it is not only those who perform, it is also those who have the potential to perform are not, but cannot perform for some reason or the other. And that's why L&D, training, coaching, mentoring became so important. Then we moved on to the next, and today you're talking about human capital, because human beings are the most important capital to any healthcare system. So don't get seeped. Of course, HR is all about people. Human resources are people. To convert them or to extract the best talent, the best performance is the organization challenge. Okay. So HRD is human resource development. HRM is human resource management. Now, capital management or talent management is a further segment where they say, well, we've identified the talent. These are the talent who have to be taken forward. Talent grade A, talent grade B who are good, but can do much better. We have a different program for them. And this is potential talent, but they're not performing. And then we put them onto personal improvement plans or coaching plans. So don't get seeped into jargons. These words, these HRM, HRD, HCM, have largely been outcomes of the digital revolution in healthcare HR. You also have HRIS. So people have asked me, what is the difference between an HR information system and an HR capital management? We are measuring the same things in many fields. Fair enough. So these are all little compartments, and they cannot be treated as silos. So don't get seeped into this. It is all a study, approach, and working with people for the best performance and productivity on table. And each organization is unique, and each of them have individual requirements. There cannot be a cookie cutter approach for everything in HR. Basis is very similar, but every organization is unique. Even two cancer hospitals in the same city on two sides of the roads have two unique propositions. I hope I could make myself clear.
Yes, ma'am. I think we have a question from the audience.
Please.
Hello, ma'am. I think the presentation was quite excellent, but in hospital, I'm a surgeon by profession. In the hospital, we have seen that when it comes to use of technology, it is delegated to a data entry operator. Okay, you make entry, you make discharge summary, you put records, you report to the notifiable diseases, and not by the person who is actually doing, who is actually reporting, who is actually observing, like a healthcare provider. How can you break this, impasse where the actual person, a surgeon, a doctor, a nurse who is actually performing a procedure or trying to report is not doing of his or her own self? That is a big problem.
Excellent question, Dr. Rana, and thank you for asking this. You're Dr. Rana, right?
Dr. Ashish Gupta.
Dr. Ashish Gupta, sorry. Okay, so now this is an excellent question, and thank you for posting this question, because I would have taken it up on one of my slides differently. Okay, now this is a challenge, true. This is a challenge, and I said in my slide, in my presentation, that whatever little I've learned from HR, in HR, in healthcare, has always been from doctors. Having worked with some dignitaries and a lot of middle and small organizations, I completely understand your question. And true, the data is prepared by data entry operators. I completely agree. The challenge in the enablers, whether it's customer service, patient service, administration, medical administration, non-medical administration, the challenge I pose to them is present the data in a format, in a form to the doctors and surgeons, so that they are interested to see that data. Give it to them in a form. Don't give them raw data. You analyze the data. For if I expect I've worked with senior surgeons. If I'm expecting a top surgeon or a doctor to sit and create data, to key in data, it may not be the right expectation, because his or her time is more important to doing certain jobs in very key areas which we are not capable of. So they're doing the medical job. Now, for all the data, please key in all data, the data entry operators or whoever is doing it, even the secretary to the doctor, and create formats. They should be enabled with formats and presentation prototypes in which the data goes to the surgeon in a format that he can actually have an ease of going through the data. Only then will he get into it. I hope I made it clear. It's like, I'll give you a very simple example. You can make the best cuisine on earth, but if the cuisine is not palatable to the person whom you served it, he doesn't take it. He doesn't enjoy it. You could make the best biryani, but I don't want to eat biryani. I'm expecting something else. So data can never go wrong, but presentation in a format which is important for the surgeon or the doctor to go through and make his or her inferences and observations is important. That is the challenge. I hope I could understand,
yes.
Answer your question.
Yeah, thank you. And in our hospitals also, we are now focusing on the context-aware communication rather than the total communication to the care provider. So the context is there, and only the context related information is. For example, a surgeon who's looking for acute appendicitis and the reports are coming, he says, report to me if the TLC comes more than 12,000 or ultrasound shows a fluid there. Only then the minimization of information will be right. Thank you, ma'am.
Yeah, absolutely. As I keep saying, the same information the same data has to be presented in different forms to different people. For example, I'll give you a simple example: recruitment. Now, who does the recruitment? The recruiter is doing the recruitment. For example, I give out to a recruiter. He sends me 40 resumes, just gross resumes. How am I supposed to work on this? So first level of analysis, he has to make certain competencies, say 5 competencies. He analyzes, gives it back to me. I analyze those. I still have the raw data with me, but I see those that help me. I take it to the next level. And then we take multiple levels of interviews, and then we take a final call. But raw data has to be presented. There is something called the DIK progression. You may all make a note. Data worked upon becomes information, works upon becomes knowledge. It's a very important management topic. I suggest all of you go through reading this. DYK, it's very important. So a surgeon or a senior doctor will have to be given that form. He has to be given the information and the knowledge, not just the raw data. If he asks for it, it's always there. Thank you.
Thank you, Shravani Basu, ma'am. Is there another? Yeah, please.
I think there are a few questions from
Please, I'm most happy. You can keep asking me as long as you are not convinced. Please do that. I'm happy to take questions.
There's a question from JSS Hospital. What are your suggestions or ideas to design or redesign training programs to improve digital adoption among non-techy tech savvy staffs?
All your questions are very interesting, and I feel you're just asking me questions about what I'm doing right now. Very, very good questions. You asked about what are suggestions, right? See, the first suggestion that I give everybody, I just said that I train and I coach and spend most of my time doing it. I work on basically I work on processes improvement and coaching. You need, if you realize there is a need for development and you talk about training, have you identified the problem? Exactly what is the problem? See, the moment you have a problem statement written down, the solution becomes very easy. So I take for granted that you identify the problem. The next is why? Why do you need to train? I'll give you a very example. So I asked them, what do you want me to do? They said, no, talkers to be able to talk to patients. Now listen, my friend, people in the front office in a hospital largely have to be great listeners and not great talkers. If they don't listen to the patients and their queries, because anyways, the moment you become a patient, including me, we are very anxious here in the mind. We do not talk clearly. We are warped in our communication. It is for the people at the first level in the entry of a hospital to find out what they actually want. They will be talking a lot of things. You tell them to go to the third room on the right, they will actually go to the fifth room on the right because mentally anxious. The moment you tell somebody, please go in for an MRI or a CT scan or a blood test, they are anxious. They are not normal. I'm sure doctors would agree. Now, for the front office staff in an organization in healthcare, it is not communication, it is listening. You have to perceive communication. If they were doing all the talking, what would the patient parties do? So for me, this was just an example. So I said, I'll coach them on listening and weeding out the undesirables. I will coach them on that. And we said we will measure, we'll give it a 6 months time. And we measured it thrice in 6 months after every 2 months, and results were exemplary. So what I'm saying is make it a very problem. The problem statement must be clear, first step. Second is, you please identify the competencies of each person you want to. You can't have a cookie cutter approach. The training program will be designed one for all, but this is very important. If in the training batch, I have 5 people with different competencies, the challenge is to design a training program taking care of all these 5 competency gaps. Somebody could be great at understanding, somebody could be great in expression, somebody could be great in data management. So bring all of this together. Normally what people do is just go download something from the internet and put it on. I'm sorry to say this, but people do it. And you can trace where they have done it from. So what I'm just trying to say is identify the root cause, identify the competency gaps, thread them into one training program, and the mode of training is very important. All the time we make a mistake that we call people and we train them in a conference room. No, not required. Maybe the basics, yes. 30 minutes, give them a manual or a handout, and then start with them and start working with them on job. Who said that there is a problem if a trainer goes to their on-site, on-job location and trains them? That becomes much more acceptable. So there are innovative ways of training, follow-ups, repeated follow-ups. You have to build up that one-on-one rapport with every trainee. I'm sorry, that is why they say the best training batch is not more than 25 to 30 people. You have to build up that one-on-one rapport. After the training, if all your trainees have not come back to you individually to seek clarifications, to seek suggestions, advice, guidance, as a trainer, I feel I have failed.
Ma'am, excuse me, ma'am. Ma'am, it's time to end this section. So, ladies and gentlemen, I'm sure that you agree with us when we say that this was an insightful knowledge filled with keynote presentation, and I'm sure our audience has had much value to take away home. Thank you, ma'am. Thank you once again. Now, on behalf of SASH 2021, we would like to present the memento as token of gratitude to our speaker, Ms. Shabani. Now, we would like to call Dr. Yashpal Sharma to present the memento to our chair, Colonel Dr. Vishal Mawar sir and Dr. Dilip Kamath sir. From that, ladies and gentlemen, let's now appreciate our speaker, Ms. Shrapani Basu, and our chairs, Colonel Dr. Vishal Marwa sir and Dr. Dilip Kamath sir. So once again, thank you.
I would like to introduce our next speaker, Dr. Harish Pillai, to enlighten us on the topic Technology-Enabled Service. Dr. Harish Pillai is an amazing visionary in the field of healthcare management, and he is a man with well-defined strategy and clear guidance to quality healthcare. It's indeed a great honor to have such a profound person amongst us today. Dr. Harish Pillai is the Chief Executive Officer of Metro Pacific Holdings, the largest private hospital in the Philippines. He was also the CEO of Aster India and was responsible for the operation and businesses of Aster Medicity. A warm welcome to you, sir, to this session. I would like to invite Dr. J.K. Das, former Director, National Institute of Health and Family Welfare, New Delhi, and Dr. Yashpal Sharma, President, AHA.
I welcome Dr. Harish Pillai, and I request you to start your presentation, please.
Sorry, Dr. Yashpal, I am very much here now. You have unmuted me. So good morning. And yes, definitely, of course, welcome Dr. Harish Pillai. And as has been told by my co-chair, please carry on.
Yeah, thank you, Dr. Yashpal and Dr. Das, and warm greetings all the way from Manila, Philippines. It's an absolute pleasure to connect with colleagues at the Amrita Institute of Medical Sciences. Also, my personal regards to Dr. Prem Nair and Dr. Dinesh. So I will just share my screen. I hope it's visible to all of you. Can you just confirm whether it's visible? Right. So I have been asked to talk about technology-enabled healthcare services, both the opportunities and challenges. So, when we look at the entire ecosystem, we have to really look from a patient point of view. If any one of us, I would deliberately use the word blessing of being a patient, either in an outpatient setup or in an inpatient area, then it's very easy to understand what the slide means. Because whatever we do, it has to be from a patient's perspective. So the entire mission and values of, even when we look at digital transformation, it definitely has to keep from a patient's perspective. And always we need to understand that in a care setup, in an acute care, or in an ambulatory care setup, care is always collaborative, it's always coordinated, and it should be easily accessible to the one who is in need of care. The comfort, especially in times of COVID-19, and thanks to Omicron, there is the anxiety levels around the world is quite spiking. Therefore, the mental makeup and emotional support, in addition to physical support of the patients, are also very critical. And it's never the patient alone, it's always the family. I can relate very easily to my own father, who is being treated in Trivandrum with my colleagues in KIMS Hospital. And I'm so far away, sitting in Manila in the Philippines. If not for the support and the seamless connectivity, thanks to digital bandwidths available with the care providers at KIMS Trivandrum, my own home in Trivandrum, and myself sitting in the Philippines, it would have been very challenging to provide care for my own father. And of course, the patient's families always and must be included in decision making. The family, especially when the care providers always have a challenge when there are multiple representatives in the family who at a different care pathway would seek additional information. Therefore, it's also important for the care providers, especially in a digital setup, to have the degree of patience, to have perhaps also the requirement to have a templatized and empathetic communication with them. It's also important to have full transparency in the care process for the patient. So when we understand that basic fundamental patient-centered care, then it's quite interesting to look at this specific slide. So if I draw your attention to the bottom half of the screen, if you look at connecting consumers with traditional modality of care, right? For example, now this conference is located at AIMS Kochi. So it's very easy to relate to the whole concept of a curative or a therapeutic organization. So imagine a patient who is coming to access care at Amrita and has already been interacted or provided with the care pathway by the clinical faculty. So the entire hospital setup, once post-discharge, the ambulatory setup or a follow-up visit in the outpatient clinic, the entire care, if it's a multi-organ issue, different specialties are involved. It could be internal medicine, it could be cardiology, it could be neurology. So that entire ecosystem need to have access to the patient. And there's so much of data which is generated within a hospital from the first point of episodic contact within a hospital. So that whole data repository which sits in the electronic medical record of Amrita, for example, that can be leveraged for long-term longitudinal care of the patient. If you also connect, imagine this patient has got access to different sorts of financing. So that's at the top. When you look at supporting payment and financing mechanism. Now, gone are the days when we look at cash transactions, that when a patient comes to admit in the ER or in a hospital setup, because you have so much of private health insurance products available, where at the point of care, it's cashless. And also the credit rating, if the patient does not have access right now to, let's say, a sort of insurance, there are a lot of fintech companies available right now in the market who can extend a credit based on an episodic need of the patient. So that is another way where technology can look at a credit rating of the patient, quickly analyze the patient's a professional background or family background, look at the risk of lending credit, and then ensure the dispensing takes place at the point of care. The third aspect is what the first slide talked about. How can a digital ecosystem understand the real next of kin, provided, let's say there's a family setup out there. But like I gave you my own personal example, there are especially in the state of Kerala, there are many of our citizens, especially senior citizens who are there, whose next of kin or the children are overseas. So what kind of a support system can we deploy for the care of aged parents in a home setup? So that is something, again, a good, intelligent ecosystem, especially in a digital framework, can support. And also, like I mentioned in the previous example, how really can you integrate a home-based care or a near-home care using the digital ecosystem and continuously provide feedback to the faculty designated in an acute care hospital. And of course, from a preventative and wellness point of view, most of us who are on an Apple ecosystem, we have an iWatch, or if you're on Samsung, there are equivalent wearables available which monitors your cardiovascular health, your constant movement, your quality of sleep. Everything is being monitored and can be provided to the care provider. Now, when we look at globally, we find that it's really an inflection point. We find that there is a huge demand from patients around the world, that almost 52% of patients around the world are now have access to on-demand care, and it's all through web browsing. This pattern has just accelerated since 2020, thanks to COVID-19. And 2.7 billion people around the world have their own smartphones. If you look at estimate a global population of 7 billion, 2.7 billion is a significant number. And 77% of customers are going online to book medical appointments. From the physician side and hospital sides, there is significant leverage of data repositories to have insights. It is quite common right now, especially if you have an intelligent electronic medical record, and where your patient is not a new patient, but has had multiple episodes before for a single care provider, you can probably assess much before the patient comes to the doctor or to the hospital by a good detailed history taking. You can probably come to an accurate provisional diagnosis much before the patient has even come and physically seen the patient. So the amount of data which is being consumed by doctors and by providers are quite significant. That is where we talk about predictive analytics, where it is very difficult to keep pace with the rapid innovations taking place either in the pharmaceutical areas or even in the therapeutic areas. So today's doctors and care providers have to be completely networked. And it's unfair to expect a single human being to be totally updated to whatever is happening at the cutting edge area. Therefore, access to predictive and analytics and some kind of an intelligent platform will ensure a better care to the patient. There is also, from a market point of view, big data market is expected to reach somewhere around 14.9 billion by next year. And because of the whole aspects what we talked about, not only from a patient point of view, even from a supply chain point of view, that we know in the case of our own country in India, there is a big demand supply gap where specialists are concerned. It's a steep pyramid. If you talk about 55,000 graduate doctors being produced per annum, the pyramid gets steeper when you talk about postgraduates being produced, just 50% of the number of graduates. Therefore, we have to now, especially teaching institutions, and I know that Amrita is already up there of deploying digital technologies for training of undergraduates and postgraduates, not just in the medical school, but also in the nursing and paramedical courses. So virtual reality is one such opportunity to not just at the level of undergraduate and postgraduate training, but even post training once they're deployed, especially when you have new surgical techniques which is emerging, then virtual training, virtual reality tools. Really, it's a bit like how we train pilots in a sophisticated simulator. So it's similar to that for training care providers. And AI deployment really makes personalized treatment possible. Many of us have heard about the impact of IBM's Watson, and how IBM Watson has made significant push in our knowledge care for prognostic care and also predictive learning in the field of oncology. So the frontiers are just being pushed rapidly as we speak. Going forward, when we look at innovating for the future, the fundamental aspects is increased accessibility in terms of convenience. If it's home-based care and you want to come and see your doctor or get an appointment, the ability to flexibly schedule either a teleconsult or a physical consult through mobile appointments, and increase communication either on a chat mode or even on a voice mode with the provider. I think that is something which consumers expect nowadays. The easy usability, especially when you have chronic disease, whether it's type 2 diabetes, hypertension, you may require to frequently access your care provider to explain to them the current, let's say, a BP, blood pressure status, or your glycemic status, so that some tweaking in the medication management could be provided by your doctor. Of course, access to records, medical records, both by the patient and by the doctor. I think that's also important in terms of usability, bidirectional. And of course, nowadays, and thanks to COVID-19, I would say that there is also a big demand for mental health apps. So that's also something which is interesting. Personalized care, the ability for not just for the patient, but also for the family of the patient to keep a track of, especially, like the previous speaker used the word biryani in a context. If you look at the ingredients going to prepare an Indian delicacy, it's rather complex. If you have a chronic disease, let's say a patient suffering from stroke or a type 2 diabetes, and also, let's say, had a history of angioplasty, easily you can imagine about 10 to 15 medicines per day being prescribed to that patient. So how do you keep a track of that, especially the dosage, the frequency of administration? So unless you have access to quality record, which can also remind the care providers in a family setting, it will be very challenging. And also such kind of an information pathway will go a long way to improve patient-doctor communications and also improve empathetic relationships. In terms of outcomes, in a post-discharge scenario for chronic disease management, if you have an ability to constantly monitor your patients either through primary care providers or, let's say, an extended care in a home care setting with the help of your home care healthcare workers, then then longevity will improve, morbidity, risk of morbidity will decrease, and overall there will be better outcomes for the patient. On a similar setup, one of the biggest challenges facing South India and many parts of Asia, especially in Southeast Asia and also China, is the rapid aging of population. And with this change in demographics, it is humanly impossible for any government of any specific country to, to make a quantum leap in the provision of healthcare workers. I can illustrate an example from a pandemic point of view in the case of Singapore. Singapore was trying to follow for some time the Chinese model of almost zero COVID, and which they subsequently realized is not really practical, because the city state of Singapore is connected to the rest of the world, because their primary economic engine is through trade and commerce and of course travel. So what they have now adopted a pragmatic approach of living with COVID, which means that intensify the testing for all arrivals. Now in the case of Omicron, while Japan has completely banned travel and arrival of airlines to Japan, now they've just modified it to permit Japanese citizens. But Singapore still permits cross-border travel. But what they have done, the reason for being extra cautious is the, the availability of very few acute care beds for the population of Singapore. The number which I recently heard is about 400 ICU beds in the whole city-state of Singapore to take care of its resident population. So that presents a big challenge of availability of human resources and infrastructure, while the need of the pandemic is completely different. And this is where technology and intelligent and practical deployment of technology can really address your real age concerns. If you look at the bottom part, when you look at spending of technology industry specific, you can clearly see that healthcare has seen an accelerated deployment of technology. And this, I'm quite sure that in the past 2 years has seen a phenomenal growth in terms of deployment. On the top right side, you can see that emerging markets, like we have seen in the past decade, if you look at compare Indian telecom with that of the American on the US side, India has actually leapfrogged in a telecom sector in terms of technology adoption far rapidly than the United States, which had to constantly keep pace up. Now in the age of 5G, where 5G is going to exponentially improve bandwidths and also for data transfer, you will find that emerging markets, especially in Southeast Asia, already having a pole position compared to rest of the world. So this is something which is going to increase utilization of digital tools, especially in the healthcare pattern. Now the bottom data is also something interesting, that if you look at, if you try to do a survey and look at from a patient's point of view, that if the patient has full access to their digital health records, would their feedback on outcomes and their experience be far better? And empirical data shows that those patients who have access to their digital health records have a more favorable outlook towards the care received compared to those who are totally blind. And the same thing also goes from a macro point of view. So this kind of democratization of access to data is what we are seeing around the world. And there is one point which I also would like to say with regards to the previous slide is India is on the cusp of dramatic changes in the next 10 years, thanks to the launch of the National Digital Health Mission. If you look at the basic ingredients of the National Digital Health Mission, we are now creating a data repository of all providers, that is hospitals and also doctors. On the other side, we are trying to link the patient data, which will be stored in a cloud format, along with this national ID, which is the Aadhaar card, and also the payment gateway through Ayushman Bharat. So you are already creating a framework for massive digital transformation of the country through a digital ecosystem, which is pan-India. I think that is the health stack, the health IT stack, which other speakers will also debate upon, is something fascinating for India. And I'm quite sure that this is going to accelerate startups and innovation where at least India is concerned. And many times we find that India's solutions, technology solutions, have got great answers for the rest of the world. And it's also highly cost effective. Just to illustrate some examples of positive impact, and some of it is already seen around us, is the digital transformation affecting you and me. Number one is telemedicine, which we have all seen since the past 1 year, past 2 years, we have already seen the rapid deployment of telemedicine. India has been at the forefront for also legislating, because earlier there were challenges with our national regulator, the Medical Council of India, and the state councils not allowing doctors to come on board to the telemedicine platforms. But now that we have a national legislation, it is much more easier. So therefore, adoption rate is quite high. We also find that in addition to hospitals, there are specific telemedicine companies in India who are not only looking at the point of care teleconsult options, but also looking at an integrated healthcare ecosystem, which connects the patient with e-diagnostics, e-pharmacy, e-home care, e-chronic disease management. Therefore, telemedicine is here to stay, and it will continue to expand in the near term. When we look at big data, that's the second component. I already mentioned before how if you're a hospital administrator, it's extremely important to understand efficient deployment of resources in terms of capacity utilization, whether in the outpatient setup or in an acute care setup in a hospital or in a non-acute care setup within a hospital. Like, one of the most challenging human resources around the world is the nurse. India itself, especially in the state of Kerala, because Kerala has got the good fortune of supplying nurses to the rest of the world. Attrition level of nurses in reputed hospitals are extremely high. So how can an administrator using big data really look at dynamic roster management without compromising the competency of the care provider? So that's where big data can play a key role in making a predictive analysis of your occupancy and census rates. Also helps in strategic planning. Like many of us, like for example, in my case, I can illustrate an example. I'm the CEO of Metro Pacific Hospital Holding. So it's a holding company which manages a network of 19 hospitals across Philippines. So as a holding company right now, we are in the process of finalizing our budgets. And the budgeting cycle in the Philippines starts from 1st of January to December, unlike in India, which is on 1st of April. So I have been, for the past 3 months, from October onwards, I've been on an immersive exercise with my 19 hospitals from a holding company point of view, not just to sign off on the annual operating plan for fiscal 22, but looking at all the way up to the year 2026. So some of the elements which go into making such long-term projections, despite COVID, like 22 is a tricky year because we do not know how Omicron is going to pattern out, especially in the Philippines. But hence, despite those challenges, we have factored that in the FY22 model. But long-term, we are looking at basically demographic shifts, mobility pattern, consumer behavior, whether there will be more demand for ambulatory care. Should we really go into primary care much more? Or should we go ahead and deploy an integrated healthcare ecosystem? So all that comes into the element and the scope of strategic planning. And of course, in a hospital setup, in Asia, this is not much documented, but in European countries and in the United States and also in Canada, we are able to monetize the massive impact of human errors which take place in a hospital setup, which makes life quite challenging and very difficult for all the stakeholders. Therefore, big data can also play a key role in eliminating, I wouldn't say eliminating, I would say minimize the impact of human errors which affect the care process. If you look at Internet of Things, it's already there, like especially in a home care setup. Now we have all sorts of wearables where you can constantly monitor patients. We talked about chronic disease management, but now there is also big demand for home ICU. So the difference between a home ICU, even though the nomenclature is home ICU, it's actually a high dependency unit where you can deploy either a nurse or, based on the disease pattern, a nurse assistant to monitor vitals, maybe respiratory rate, maybe pulse rate, and other parameters can be monitored real time and sent to a central command center. The risk assessment teams, which is sitting in a telecommand center, can look at whether the care can be continued in a home setting, or should the patient be shifted to a transit home, which is much closer to a hospital, or finally actually admitted back to the hospital. So that's also something which IoT can always look at. The most interesting aspect of deployment of IoT also, which we have seen in a hospital setup, is basically early alert mechanism, which many hospitals also in India have deployed. This is based on both the combination of diagnostic data from laboratories and also physiological monitoring in a inpatient setup, where you will be able to predict which are those patients who may require intensive care setup. Therefore, imagine a collaborative arrangement between an ICU clinical team and a non-ICU team, where the doctors in the ICU setup can predict much ahead of time that X patient is a possible admission in an ICU environment. And this can also prevent unnecessary morbidity or even mortality in a hospital setup, because you're able to predict the disease patterns. Virtual reality, we already spoke about in terms of training of care providers, but it can also provide better patient experience, especially when you talk about occupational health training, where you may have to recreate the home of the patient within a hospital setup. So physically making that structure may be rather difficult, but with the help of VR, you can use augmented machine learning ability, looking at 3D holograms of the home environment and deploy that into a VR environment for the benefit of the patient. AI, we are already seeing at the bottom end, which we are already seeing rapid deployment is in the field of predictive and analytics, and also in the field of pathology, dermatology we are seeing, and of course imaging. A classic example from imaging is what we saw in China. Most of you have heard about Alibaba, which is a major tech player in China. Alibaba was one of the pioneers to deploy AI in quick reporting of HRCTs, which led to rapid diagnosis of COVID-19 in patients with a clear pattern of pulmonary changes. We are also seeing deployment of AI in tissue pathology, especially it's sometimes difficult even in highly trained pathologists to make that kind of definitive diagnosis for rare tumors, whether it's to do with solid tumors or even blood tumors. And that's where AI can augment immunohistochemistry to come to a certain degree of accuracy for diagnosis. And of course, the most interesting example in our lifetime is COVID-19 vaccines. I remember somewhere in March 2020, when COVID was just entering India, many of us were, while we said that, yes, we hope that there will be vaccine, but realistically speaking, none of us really thought that this sort of accelerated approval by the regulatory agency, development, regulatory approval and deployment of vaccine within 12 months. This is actually breaking the world speed record in our lifetimes, or even in human history. This COVID-19 has actually shown that deployment of machine learning, artificial intelligence, and of course, high-tech manufacturing has helped us to produce. Now, if you look at Omicron, most of the major vaccine manufacturers are already talking about tweaking their available vaccine models to ensure that the first batch of booster vaccines would be available by the summer of 22. So that's how fast AI is helping innovations in not just vaccine, but also improving the armamentarium of drugs which is available for care of patients. So we are actually, mankind is in a better place where Omicron is concerned, even though we will need about another 2 weeks to figure out exactly how Omicron is going to behave. But there is a silent, I would say, comfort at least among the doctor community around the world, that it's not so bad. Like we have already confronted Delta, therefore Omicron should not be such a big challenge. Alexa, the last point is how operational efficiency, especially in a hospital setup, patients are very demanding nowadays, and rightfully so. They have a choice of providers. So why should they come to X hospital and not Y? In addition to, of course, the credibility and the competence of the doctors and the infrastructure, service element is of great premium, and the patients are willing to make the choice of hospitals based on the comfort what they have. Therefore, tools such as voice assisted AI tools such as Alexa can also not just make the life of patients better, but also that of nurses. Because if you do a data search of the use of wrong use of nurse call buttons by the patients, you will find that most of it is nothing to do with nursing care, but it's for ancillary services. And that's where it can be of great help. In a home care setup, especially for the geriatric group or elderly parents, medication alerts through voice-assisted AI tools can be of great help of timely reminders. to take their medicines. Now, when we look at broadly technology trend, we spoke some of it already. We talked about AI and machine learning. We talked about wearable technology. Genomics is something which is in vogue, especially in the field of oncology. We are seeing that it has adopted age-old traditions of Ayurveda and gone into personalized medicine. And that's thanks to the unlocking of the human genome and the immune modulation therapies which are already in vogue. 3D printing, Amrita in fact has pioneered manufacturing with 3D printing, especially in healthcare, especially for modeling of cardiac valves and the structure of the heart. So this is a good example from Amrita itself of how 3D printing is here to stay and makes a big transformational impact in the cost and quality of care. 5G, I already mentioned, the pipeline for band and data transfer is going to exponentially increase, and this will not just increase the adoption of digital in healthcare, but also reduce the cost exponentially. You can see that some of these things, when we talked about RT-PCR as an example for COVID-19, prior to 2020, RT-PCR was one of those, I would say, elite diagnostic tools which was not much frequently used. But today it has become a common lexicon. It is almost like, when we use the word Xerox, which is a brand for photocopying, RT-PCR is similar to that. And in tomorrow, I'm sure that this is itself not just for COVID-19 testing, but the same molecular diagnostic tools can be used for much more, not just in infectious diseases, but also in other branches of medicine. So we find that there is an increased deployment of various tools available, mostly for diagnostic and also for therapeutic aspects. And this is also here to stay. Now, looking at where we are right now in 2021, we are at the fag end of 2021. So AI and Internet of Medical Things has really picked up the big chunk in terms of usage. Telemedicine, we spoke about it, big data and analytics. Now, one interesting aspect which WHO subgroup is really looking at is that what is the future of mankind? Can a Wuhan type of incident, like we still are not clearly sure about the origin of COVID-19, which we think, many of us think are from Wuhan, but we do not know for sure. But how can we better prepare ourselves for the next pandemic? I mean, it's for sure that there will be another pandemic sometime in the future. Hopefully in 2022, COVID-19 would become an endemic. And some of us are really praying that Omicron will probably crowd out Delta around the world. And hopefully the infections would still continue to be mild and the whole world will pick up some sort of herd immunity and then it dies off. That's what we are all hoping and praying for. But we need the help of early detection systems to prepare us better. In the world of rapid, where the world is a village thanks to aviation, where it's extremely difficult to close out countries to prevent the spread of an epidemic or a pandemic, it is very important for us to constantly monitor real time where these diseases are emerging and how we can localize it and manage it better. So that's where big data and analytics is going to play a key role. So when we look at key drivers of technology adoption from a consumer point of view, consumer can also be a patient, a hospital or also a provider. 55% looks at how it can better improve workflows. 52% think of creating a better patient experience from all the points which I've already spoke about before. 47% think that it's to do with increased access for patients, and 43% feels that compliance of patients to a drug regimen or even follow-up care will greatly improve because of technology and real-time reminders and follow-ups. But having said all these things, there are also real-life challenges. The number one challenge is clearly there is an inequity in technology access. Unfortunately, we live in an unequal world. Even if you look at the subcontinent of India, I like to call India as the United States of India, where southern Indian states have much better literacy, much better access to public health systems, and of course, much better deployment of digital platforms compared to the larger North Indian states. So there is already an inequity of technology access due to geography, and I would say also political ideologies, because in India, healthcare is a state subject. It's in the concurrent list of the Constitution. So cost of access is something important, that how can someone sitting let's say in a poor village in Bihar or in Uttar Pradesh, how can that person have access to what we call as minimum assured care through a digital platform? So cost of access is something which nations need to really think about. Bandwidth is a big problem. Now, the government of India has deployed one of the world's largest backbone in terms of digital backbones through the fiber optic cable laying across all the gram panchayats in the country. The hope is that this kind of a fiber optic, physical fiber optic layout will actually improve accessibility for our citizens for all kinds of services, including healthcare. But there are many parts of the world, especially in Africa, where such a luxury does not exist because of lack of resources of their specific government. So that remains a challenge. Most of the world, when we talk about the population coverage, many of them have access to basic mobile phones, but clearly, if we can deploy more smartphones, then the adoption rates and also the feature-rich phones will really help more citizens to have access to quality healthcare. Changing demographics really pose a big challenge in digital adaptation. South India is rapidly aging. China is already the world's largest geriatric country. Many parts of Southeast Asia is rapidly aging. So when you have an aging population, it is a double-edged sword, in sense that elderly people cannot keep pace with technology changes. Therefore, there is an entry barrier for adoption where elderly population is concerned. Digital illiteracy is also a big challenge, that because people are not aware of what are the features and what are the benefits they can have if they have access to digital platforms. So this itself is an entry barrier for large parts of the world. And of course, visual and tactile challenges, again, to do with demographics. Eyesight is a big problem. The sense of touch is a big problem for many parts of the world. So this also is an entry barrier. The third point is ease of use and poor training. Many designers, especially there is a demographic quandary that most of the programmers and designers belong to a younger age group. I would say not even millennials, even younger than millennials. So their worldview is so different from a generation which I would say, let's say, born in somewhere in between 1940s and 1950s. So it's a challenge in terms of the design of user interface. Also poor design in terms of self-use tools. What I mean is, imagine you buy a new mobile phone and you want to set up your mobile phone and you need to connect the mobile phone to its own cloud-based ecosystem. If there is no easy to use videos or even an app which can really configure all the features with the help of a retinal scan or a finger or a thumbprint, it's going to be a big problem for many citizens around the world. And also rush to market. Because of pervasive competition among brands, many of them do not test the application of their technologies with clear focus groups and obtain feedback from focus groups. So this rush to market challenge also results in poor design of the product, and that is also an entry barrier. The fourth point is cost of technology deployment. There is a certain gestation period and incubation period. There's a lot of trial and error involved in deploying the right tools, especially in the healthcare space. And also accessibility to quality knowledge workers is a big challenge. Like if you look at the state of Kerala, many of you are sitting in Kochi. Kochi has got a vibrant startup ecosystem. You have the smart city, which is close by in Kakinad. You have Info Park there. So there is a cluster of knowledge workers, which is already, you have QSAT in Cochin. So all that actually supports creation of a vibrant ecosystem. Same as why is Bangalore the Silicon capital of India? Mainly because of the accessibility to knowledge workers. So that remains a challenge for many parts of the world. And sufficient product development funding, because technology is rather fragile, especially in the developmental stage. Sustained funding from people who have faith is also something very important. The next problem is, fifth problem is rapidity of technology obsolescence. After spending so much of time and money and effort to launch a new product, suddenly you realize that you're already obsolete even before you reach your market. So that's something which designers are thinking about now. Especially we are looking at threshold of hardware design, that how robust can your hardware be, that you don't have to throw away your hardware after such a big elaborate developmental cycle? Can it have a degree of future proof, that can it at least last a decade? What is the limit of software patches and upgrades which can make sure that the basic features of the product you have deployed does not become obsolescent? And also the fickle nature of human behavior, that people, especially when the cost of technology comes down, people really look at a rapid movement from technology A to technology B. So that also is a problem because of human behavior. Next is the sixth point is fragmented payer ecosystems. I touched about it a bit earlier. We have a problem that in the banking space, like I can give you the example of India, where the parliament is right now debating about banning Bitcoins. It's something, it's a moot point to debate. There is a difference between Bitcoin banning and also the rapid digital adoption in India thanks to UPI. And if you all recollect the effect of demonetization which took place, there is a clear graph which shows that post demonetization, UPI usage has dramatically increased across India. So the amount of investment paid by governments around the world to accelerate digital adoption, reduce the entry barriers, I think that's also an important part of increasing that. We also lack a super payer app, which it's like a one size fit all kind of a payer app, which can support all the digital ecosystems which are out there. And of course, Glacial pays for financial innovations. The seventh point is a lack of standards. Unlike aviation, unlike even medtech, we do have a challenge in terms of global lack of standards, which creates problems in interoperability. We have global barriers. This is mainly to do with geopolitical issues, which prevents technology which has really worked in one country to be adopted easily in the other. And of course, there is also a taxation issue in terms of the financial integration. And you've seen the G20 adopt a global platform for having 15% corporate tax. This is mainly because of the tech majors such as Google, whether it's Apple, Twitter, and others, looking at low tax regimes to have their big centers of innovation. But now with this 15% tax, there is some sort of equity around the world in terms of governance and to keep pace with the regulations. The eighth point is data privacy. We are living in the world of Pegasus. You know that Pegasus is not just a challenge in India, but it is a problem for around the world. Today morning's headline news was that certain US state government, State Department employees in Africa, Pegasus software was used to survey on them. So this is a big challenge where you can imagine the status of a common man or a common citizen who is constantly at a risk of covert surveillance, not only from security agencies, but also from commercial entities. So that's a big problem. Ownership of data, even though we all say the right things about that an individual should have real ownership of data, is still a bit fuzzy out there, that in the real world, who actually has got control over a citizen's data. And of course, quality of encryption. And that's where blockchain technology is going to play a key role, that we need to have some sort of global standards to ensure encryption of individual data. Of course, the last set of challenges, silo approach to user needs, we have already touched upon it. There is not a clarity on integrated approach to technology adoption. We talked about interoperability and lack of future proof. So I guess this concludes my presentation. Thank you.
Thank you, Dr. Harish. It was really excellent presentation. You gave on digital transformation in healthcare and especially the challenges. You will agree with me that COVID pandemic taught us lot many things. The challenge of COVID pandemic was converted into opportunities, and most of us, in health sector, they developed their institutions in terms of infrastructure, in terms of manpower, in terms of supplies. And I can say that we are better equipped than what we were 2 years back. So as far as you said about the involvement of the patient-centric care and involvement of the family, COVID also taught us that we need to involve the families. And After the involvement of the families, are, you can say, the patient, when we started giving them care at home, or we involved the families in the patient care in the hospitals, the health outcomes were better. Digitalization of the hospitals was also seen a lot after the pandemic effect. We really started believing on the digitalization. Our doctors were giving teleconsultations, sitting at home, and many other things came up, as you told us. The improvement was not only in the private sector or government sector. You can say that improvement after the pandemic, you can see from the primary, secondary, and tertiary care healthcare centers. So in government sector also, we ensure that the health structures from primary health centers, especially the health and wellness center concept came in with the coming up of new policies of the government, and the health and wellness centers in sub-centers, primary health centers, and some of other institutions are no better equipped to deal with the COVID. You presented really very well. I'm really very happy, and I thank you very much and congratulate you on your presentation. Before we take up some questions, I will request Dr. Das to say a few words, and then we have some questions from the audiences also as well. Some people have given the list. Please make the list so that we can accordingly go on. Dr. Das, please.
I think Dr. Das needs some help for unmuting. Yes, left a message in the chat box. If the organizers, someone can unmute him.
Thank you, Dr. Pillai, for your intervention. And now I can speak now. Yes, thank you so much. Yes, I must congratulate Dr. Pillai for such a comprehensive, but on the same time, such a lucid presentation, and making this aspect so simple. And the thing is this, whether we are having all those challenges or whether we are not ready, but there is no other alternative but to be with this digital kind of thing. And yes, of course, we need to be prepared and we need to go into it. Yes, for every mechanism, everything, the challenges are there. But the only one thing is this, at the end of the day, still the medical care is more of the labor intensive one. The hands will be there. But with the help of these interventions and artificial intelligence and all those things coming up, and along with those support, this is definitely going to be a long way. And I really don't have enough words to thank you for such a beautiful presentation. And yes, Dr. Yashpal, I think we are having very limited time available with us, so let's open for the questions. Thank you.
There's a question from A. Suresh Babu from Andhra Pradesh. Please explain recent techno trends in oncology.
So thank you for the question. That's what I was giving the example of how modern medicine and Ayurveda, our age-old science, has come closer together thanks to oncology. Gone are the days when we used to use gunshot therapy. Gunshot therapy is that we really do not know the nature of the disease. We have some idea about the disease, but we assume that X amount of drug is going to work, and and that is how for many decades cancer therapy was going on. But thankfully today, thanks to genomics, bioinformatics, and this entire that's what we talked about, this melting pot of information technology. So you have already decoded the human genome, the mutations which are responsible for X tumor, in terms of immune modulation therapy, which is going to work more effective for the drug. And based on that, that patient's demographic setup in terms of his lifestyle, in terms of his food habits, you can tailor make that literally for him. So it is quite evident that the new generation, let's say medical oncologists today, the kind of advantages they have, many generations back, none of our medical oncologists had that kind of luxury. And it's all to do with the power of technology, because it is made, like Dr. Das said, things have become much more simpler and easier today. So currently, let me also touch upon one other challenge which all of us are facing, is that it's when you look at the cost of care especially in oncology, is skyrocketing. I mean, sometimes you are also shocked to hear crowdfunding platforms to look at some specific drug, which we are not talking about lakhs or crores. We're talking about 15 crore, 20 crores for one specific drug, which has got therapeutic thing. So it's a moral dilemma. So the moral dilemma is that can a specific therapy really make a qualitative difference in a person's lifespan, is something what we need to debate upon, versus is it just to do with let's say you do a CAT scan and find that okay, the tumor size is decreasing a bit without making any substantial change in the quality of life or longevity of life. So ethics apart, I'm quite comfortable in saying that the sophistication of technology today has given much more choices to our doctors.
Next question is, what about adopting a hybrid form of clinical consultation in the future hospitals?
So like Dr. Das and Dr. Yashpal also mentioned, you cannot will away human beings. Healthcare is always going to be a high touch environment. If you think it's going to be fully virtual, I'm afraid not. You cannot do away with the human being behind that. So illustrating this example is, if you look at the robotic surgery, especially Da Vinci has been patented by Intuitive Systems. And if you look at where did they get their technology, they got their technology from NASA. And the whole idea was that if you remember in the 70s, you had an orbiting spacecraft called the Skylab, which was put into space by NASA. And the debate was that if an astronaut in space get an acute appendicitis, what can you do? You cannot fly down the astronaut from Skylab to Earth and operate upon it. That's where they were looking at using surgical robots, which can be controlled from, let's say, from site, using some kind of a telemedicine kind of a setup and manipulate the robot. What we see in our surgical theaters is basically the surgeon sitting in one corner of the theater and the robot is on the top of the patient and you can manipulate it. But the future, I suppose, is what we call this concept is slave master technology. So it is clear that the master is still the surgeon and the robot does exactly what the surgeon wants. In orthopedics, for example, when you talk about robotic applications in orthopedics, especially the shaver, now there is a surgeon, an orthopedic surgeon is clearly there with the robot when it actually cuts the bone up to the last nanomillimeter. Let's put it that way. But still, it's a slave master kind of a thing. So, in my opinion, the hybrid approach is here to stay. If you're a fan of science fiction, and if you watch Star Wars, and if you're fond of the doctor on Star Wars, USS Enterprise, even he uses it's actually a human doctor who uses a handheld portable diagnostic and therapeutic tool to cure his patients. You're not talking about some kind of a robot or someone who's a doctor. So I'm afraid you have to live with this hybrid world.
That's true. That's true.
To you, in India, where gradually the healthcare is being provided more and more by the private healthcare sector, and the patient information is considered to be a business capital, how can we look forward to these private players sharing the patient-specific information amongst one another? That is a big challenge. How we can overcome that, speed breaker.
So thank you, doctor, for that question. So like I mentioned, I think India has gone far ahead of other countries by having a national mission. That's why the National Digital Health Mission gives us the regulatory framework for data privacy. It is very clear and there is no ambiguity in the NDHM, which has already been passed and approved, that data, the ownership of data sits with the patient. And unless you have explicit informed consent by the patient, neither the hospital nor anyone else can look at monetizing that kind of a data. So we are actually good. There is no ambiguity in that. We have a good regulation in place. And I think that is what is going to help our patients going forward.
I have a question. Can I take a question from here, please, to Harish, Dr. Harish Pillai? Can I take a question from here?
Yeah, sure, please.
Yeah, I just have a question, Harish. You talked about home ICUs, right? My question is, how do you plan a framework to implement home ICUs? I'm sure understand that there would be a framework to onboard people, staff, train staff to look after this, compliances, governances, in the event that a case could get worse or unfortunate death could happen. How do you plan to handle this framework?
So there is a whole separate ecosystem which includes development of SOPs, identifying the right manpower, training of manpower. Then, of course, you deploy technology solutions, remote monitoring, telecommand centers. So it's actually an integrated approach. Like the organizer was saying before, till few months back, I was the CEO of Aster India. And we had in Aster, there was a network of 14 hospitals spread across 5 states. In the state of Kerala, there are 4 hospitals, including Aster MedCity in Kochi. So some of the things which we pioneered was home care, especially home ICUs. And recently, the Joint Commission International, in fact, the Aster Home Care vertical is the first in India to be accredited by the Joint Commission, which is a global standard for that. So it's an emerging field, especially because cost of care in an acute care setup for patients with chronic disease is extremely prohibitive. And there is no point in families being converted into acute poverty because of episodic encounter to healthcare. That's where I think home care is going to act as a panacea. And yes, you need to create that ecosystem for safety.
Thank you. Thank you, Harish. Otherwise, an excellent presentation. Very, very insightful. Thank you.
Again, and now over to the organizers.
Thank you, sir. On behalf of SASH of 2021, we would like to present a memento as a token of gratitude to our honorable speaker, Dr. Harish Pillai. Dr. Prem Nair, Medical Director of Amartha Institute of Medical Sciences, to present the memento to Dr. Yashpal Sharma, AHA President.
To know more about healthcare workforce towards digital future, I would like to call upon Dr. Alexander Thomas, patron and founder of Kaho. With his vast experience, he will address us on preparing healthcare workforce to deliver the digital future. We welcome you, sir. Now, I request Major General Jagdas Singh and Dr. Prem Nair to chair this session. I would like to request our chair for the session, Major General Jagdas Singh, to kindly introduce our speaker, Dr. Alexander, sir.
Thank you for unmuting me. Good afternoon to everyone, and good afternoon especially to my co-chair, Dr. Nair. And, it is my very pleasant duty to introduce Dr. Alexander Thomas. I don't think so Dr. Alexander Thomas needs any introduction. He's such a well-known and a visible figure, I would say, on the platform of our healthcare industry. And he brings to his session and his talk almost about more than 30 years or 3 decades of experience in the government, in the state, in the private, and in the mission hospitals. So it's a huge kind of an insight that he has into the healthcare systems, which function and all these kinds of healthcare organizations. And we couldn't have had a better person to give us an insight as to what is the requirements of how do we prepare the very important aspect of our healthcare, that is the human resources. Speakers earlier in this session have also spoken about human resources. In fact, Dr. Sandeep Reddy has touched upon it. Dr. Ms. Sharbani Basu has also talked about it. So we are going to have a sort of a greater exposition on this from Dr. Alexander Thomas. Over to you, Dr. Alexander Thomas. We are all ears and waiting for your presentation.
Yes. Thank you,
Welcome,
sir.
Alex.
Yeah.
Good to see
Thank
you.
you, Prem. Thank you, Prem. Since I'm in a place where the internet is not very stable, I've actually shared my presentation and I request you to share it, and I'll be here for the questions. Thank you once again for this opportunity. Good afternoon to all of you. I want to specially thank the organizers of the International Conference on Safe and Sustainable Hospitals 2021 for inviting me to this important event. The events of SASH are always looked forward to, and I've attended quite a few and appreciate the high quality and the information that is generated. I bring greetings from the Association of Healthcare Providers India. As many of you may know, AHPI was founded about 10 years ago. We have at present a total of 19 state chapters in most of the major states and regions, and we have close to 12,000 members across the country. AHPI is involved in many activities, including training, including policy advocacy, including lobbying, and we have been successful to some extent in many areas, like the increase of undergraduate and postgraduate courses, both with the MCI and with the National Board. We've been also successful in various other initiatives, including the recent ones where the PMJY rates which were increased. We are looking forward after a meeting with the Health Minister of India towards the CGHS rates being revised. The other important activities that we're doing at present are trying to ensure that there is no shortage of nurses and other allied healthcare professionals required in the country. Permit me to share the screen, please. The topic of my talk today is, I think, very important, especially in the present context of the pandemic. Technology, we know, is absolutely crucial now. A few years ago, it may not have been, but today it's very crucial in the delivery of healthcare. We all know that this is a very important aspect, digital healthcare and technology. But quickly, just to refresh our memories, let us go through what would be the advantages and how we can leverage the use of digital healthcare and technology. The first point is access, and especially during this COVID pandemic, we know that we've been able to provide reasonably good care to far-flung areas through the use of telemedicine, etc. Quality of healthcare definitely improves through the use of technology. The cost definitely comes down. And these are two important areas: increase of cost and decrease in quality to make healthcare affordable. Technology will also help us make healthcare less chaotic and get it more organized. It is, I think, without doubt, technology has made healthcare far safer. And especially if you look at emergency situations, be it a heart attack, be it a stroke, I think medical care is made available using technology at a fraction of a time that was earlier used. Most importantly, technology can be used to provide patient-friendly services. And I think that is the reason all of us are here in this sector. And another equally important point is that technology also facilitates the healthcare delivery to be more environment friendly. In this area of the pandemic, we have seen, and I think this is going to improve, we can quickly detect pandemics and epidemics. At some point, the other big area of concern, cancers, it is not too premature to say that there could be a cure for all cancers in the near future. And also, if you look at the diagnostic tools, technology makes these cutting edge, makes it cost effective, and makes it portable. So it is available at the patient's bedside. Realizing the importance of technology, as far back as 2017, AHPI and UNBI had recommended to the government. This was actually at an UNBI conference. I was the president of UNBI at this time. We had a meeting of experts from different other education sectors like the IIMs, the National Law School, Chartered Accountancy profession. And we had actually made a recommendation to the government saying that in the MBBS curriculum, it is important that we put in a 6 to 8 week technology course so that people passing out would be aware of technology and also could leverage technology in their day-to-day clinical practice. Of course, we are talking about the younger generation when I talk about including this in the curriculum, but there has to be an option also for those of us in my age group, those of us who haven't had exposure to technology and to the digital era. There needs to be some mechanism where they also are sort of clued in. They also know the basics and can use it for their benefit and for the benefit of their patients. So how do we empower medical professionals? Since 1917 and especially over the last couple of years, AHPI, along with many experts, renowned experts in the country, are looking at how do we empower medical professionals. And these were the points that came out, that we need to develop and implement capacity building. And capacity building, I think, is crucial, especially in this emerging area. We need to impart the basic knowledge so that all of us in the medical profession, and nurses, doctors, allied health administrators, will have some idea of what are the potential of technology of the digital era, so that we can leverage it to our advantage. We're also looking at the awareness of technology application, the preparation for technology-led advancements and innovations. And finally, that we need to collate all this knowledge and experience and deliver it to the target population. And when I say target population, I mean all our colleagues. So we were looking at how we could help spread the message of the digital future, because whether we like it or not, technology has come to stay, will play a major role as we continue to progress in our country. So over the last couple of years, we've sort of curated some topics which we thought are important and would cover the basic aspects of technology. It would help us help the medical professionals to develop a balanced view of what is in store, what can be done, what are the disadvantages, what are the laws we need to be aware of as technology becomes incorporated, becomes a part of our life. So the introduction to healthcare technology and its practical application is something like one of the founding stones, especially for those of us who have passed medical college some years ago and who are already in clinical practice. We need to congratulate the Government of India for the introduction of the National Digital Health Mission. Actually, I would suggest that if you have time, if the listeners have time, that you go through this. This is, I think, a very, very well thought out enterprise. And if it is implemented correctly, this is going to make a huge difference. There's going to be a huge transformation of healthcare in our country. And this would be a transformation, not only for our country, but it would be a leader to other countries, even developed countries in the globe. So here we will also look at the introduction, the importance and basic terminology in health technology, and the role of technology, the role of IT managers, IT departments in healthcare. This applies both to a large hospital or to a single owner clinic, etc., and different types of healthcare institutions. We should also try and impart the understanding of healthcare data and standards. I think healthcare data, healthcare analytics is now widely talked about. There's a lot of learnings which we can implement to help improve the standards that we set in healthcare. In the light of the pandemic, it is also important that as a basic core knowledge, we need to understand a little bit about digital epidemiology. Now, under the subhead of technology-led healthcare, I think there are various points we could look at. Clinical decision support systems is, of course, self-explanatory. I won't go into too much of detail. Artificial intelligence and algorithms in healthcare are being more and more frequently used. We have examples of ECGs being read by artificial intelligence. We have examples of X-rays being read by artificial intelligence. And we are told that these are more accurate than the human reporting. But to make a point, I think we need to use this. This provides quicker diagnosis, because in the case of reporting of X-rays or reporting of CT scans, we have used it especially during the COVID time with a partner called 5C, where chest X-rays and CT scan chests were being read using inputs from artificial intelligence, and we were able to get information regarding the severity index of COVID very quickly. This was a big help. Patient monitoring systems, again, this is self-explanatory. There is a huge advance over the last few years into monitoring patients, both in the hospitals and at home. So this is an area where all of us medical professionals need to have an idea as to where we stand. The role of IoT and point-of-care devices in healthcare is equally important. We know that point-of-care devices, again, enable the clinician to get results quickly and to start the appropriate treatment as soon as feasible. Quality management using technology is another important area. With the advent of NABH a decade ago, there has been a definitely positive movement towards quality in healthcare in our country. Using technology can actually fast forward that and can make this more widespread, can make hospitals more accountable, and gives the patient the access to what methods are being used in hospitals. Technology for infection prevention, especially in this time, and waste management is something that all of us in the healthcare sector need to be aware about. As I mentioned earlier, development of medical devices and ensuring quality of medical devices. I think these days you hear of one medical device almost every week. So there has to be some method in ensuring that the quality of the medical devices are above board, and the patient is actually, the data which comes out is validated and we can be sure about it. Smart hospitals are already there, a few hospitals over the country. And I think this is the way that the hospitals are going to go. If you look at our hospital situation today, I think in every city there are 1 or 2 hospitals which are paperless. There is a first step of this, but as we go along, the medical professionals need to know how to operate in the environment of a smart hospital. Another interesting area which came up was careers in the healthcare digital space. Actually, if you look into this area, it can actually be termed a different subspecialty, if you may call it so. People who are tech savvy and are interested in this, there are careers as technology inputs into healthcare sector increases. Now, some of these other subjects which I talked may sound very high funda, but I think it is important that all of us know a little bit about what is happening in these areas: simulation and organ modeling, tissue engineering and 3D printing, augmented and virtual reality in healthcare, robotics and biomechanics in healthcare, futuristic health technologies of the next decade. I think it's all these modalities are being used in various parts of the country, not only in healthcare delivery, but as in education. We're using this in research, especially in pharma research. So a basic idea of these subjects will definitely prove helpful to the medical fraternity as a whole. Each of these topics that I mentioned and what I'm going to talk about later, each of these topics in this conference, I've seen the list of the speakers. Each of them is an authority by himself, herself, and each of these are going to be covered in detail. Now, when you get into healthcare technology and the digital era, you also need to be aware of the regulatory, the policy, and the practical aspects. It is, I think, important for those of us in the medical fraternity who use this, and all of us will at some point be using this, to be aware of where we exactly stand. So it is important to know the legal, importantly, the ethical and intellectual property rights in healthcare technology. Another area which is equally important is cybersecurity, because as technology is more used in hospitals, there is more risk of hacking, there is more risk of other issues like this. So I think it would be imperative, especially those working in hospitals, that they need to have a basic idea of how to ensure the security of their systems and the information that they hold. It is also, as we work in the country, it's also important for us to know the policies of the country. Recently, I think the data privacy bill was passed. So things like that related to health, all of us who use it need to know what the policies are. We need to know what the guidelines are. It's also important to have some idea of health technology assessment. Many of my colleagues say, no, it's not for us. We have no idea how to, we'll get somebody to do the technology assessment. But I think a basic health assessment we should be able to do by ourselves. The procurement of technology in healthcare, we always need to look at the economics versus the outcomes. We have to ensure that whatever we do is feasible and that the outcomes are good. So it's economics versus outcomes. I think in all this, we need to remember one very thing. Important factor is that the patient is central. Many people talk about the disadvantages of the digital area, of the digital era. We talk about the human touch is missing, that it's all machines. So I think while we're talking about the digital era, it is important that the healing touch with empathy and compassion is not to be compromised. I think empathy, compassion, trust is very crucial. It is the cornerstone of the patient health professional relationship, and this should be maintained at all costs, and technology should be used where it helps reinforce these matters. The way forward, I think it's very easy to sit and talk and say, you have to do this, you have to do this. So as an organization, what has AHPI done? What is the AHPI doing in ensuring that our workforce is adequately prepared in the digital area? We will continue to lobby with the government, and I know there are many speakers here from the government, and would request them also to ensure that the technology, the digital era, the information regarding this be included as a subject in the curriculum, be it MBBS, be it post-graduation, being nurses, be it allied health. Of course, this will look at only the future generation. The present generation, HPI has actually tied up with the Public Health Foundation of India and two very eminent institutions, the Indian Institute of Science, Bangalore, and the Indian Institute of Space Technology in Trivandrum, which is a unit of ISRO. And together we have come up with an online certificate course in healthcare technology. This is a purely online session. It's got a convenient schedule. It's flexible, it's self-paced learning, and it will be completed in 2 months. We've got the best of faculty from all over the country. This is not a marketing slide, but it's just information to tell you that this course is available. It's very reasonably priced. But for those of us who need to know the basics of how to fit in with the digital era, I think this is something you will find very, very useful. We have also, once this course was started, we also realized that there is no comprehensive book on technology for healthcare professionals to provide the basic material so that people could function efficiently in the system. We have started work on this book, Technology for Healthcare Professionals. It's due for release sometime in the middle of 2022. And we hope that this will also be another avenue for our workforce to be empowered as we go more into the digital era. So I think it's important for all of us to realize that technology is not to be feared. It is only to be understood. So let us in our country, let us leverage technology to provide quality, affordable, and accessible healthcare delivery. I think none of us have any doubt as to the use of technology, but it is important that we balance technology, make sure that it is not our master, that we use it to facilitate access to quality, affordable treatment, and that it is our hope that technology will fast forward our journey as we work towards universal health coverage to all our citizens. Thank you very much.
Thank you, Dr. Alex, for an excellent presentation. As always, I think the subject that you have spoken about, preparing healthcare workers, is a very vital and very important aspect of technology and digital health, particularly now that digital systems have kind of taken over healthcare in all its aspects. And literally every piece of technology in healthcare is a computer. So I think it's very, very important that we look at training our healthcare workforce at all levels in healthcare technology. Dr. Jagtar Singh, would you like to take over?
Yeah, thank you, Dr. Nair. That was very, very pertinent, observations that you have made. But I think the last slide of Dr. Alexander Thomas's presentation, I think, said it all. When he said that we need to leverage technology to provide quality, affordable, and accessible healthcare. And that resonates with the theme of the conference so well. And it just underlines the fact that if our healthcare, is under transformation, and there is no doubt about it, the digital services are going to be an important factor. But these digital services or this digital technology, if we have to assimilate in our healthcare delivery systems, in our healthcare organizations, then it becomes all the more reason and all the more important that our healthcare workforce, our human resources, is well prepared and well trained for the future. Well, if the healthcare workforce is not prepared with, I would say, the necessary knowledge, skills, and the attitude, I think we just can't have the dream of transforming our healthcare to the levels that we want in the future. So the challenge, of course, remains. The workforce needs to be, trained at various levels, at various areas, and in various ways. And that is where I think Dr. Alexander Thomas's talk gives us a wonderful insight into all these aspects of how do we prepare our human resources or our workforce for the digital future that we see in our healthcare system. So with these words, I would like to throw open the session, I think, for a question-answer session. Maybe I think the physical audience can take it up first and then the virtual audience.
Right.
So there's a question from the participants from Dr. Gopi Lakshman Y from Visakhapatnam. Please let us know few techno modules used in healthcare quality management.
Dr. Thomas, you like to unmute yourself?
No, I just got unmuted.
No problem.
Thank you. I may not be able to give a very specific answer to that, but we could find out. There are modules, and basically I have tried to put all the information together in this course and in this book. I can try and get you that information offline.
There's a question with the hospitals having very migratory type of, healthcare staff like interns, PG students, resident doctors, nurses, and a high attrition rate, tackling and training manpower in technology advancement, a very costly affair, will not be very beneficial in short term because of these, leaving the organization. You train them according to your own things. How do you plan to handle such issues in India?
Yeah, thank you, sir. I think a very important question. I think we'll have to divide it into two areas. One is the future, young people who are going to join the profession, who are in the process of studying for it, and that's where I think many of I can see many of my colleagues here who hold high office in government and who would be able to influence the government to introduce this as part of the curriculum. I think it's very crucial and a very important step. A few years ago, I know it's very difficult to get this into the any curriculum. I'm not talking only about doctors and nurses. I'm talking about allied health. I'm talking about nurses. I think a few years ago, you may not believe it, but communication was not part of the curriculum. And we lobbied with the government. It took us 3 years. It's included. So I think if you look at today, the digital era, health technology is a very imperative part of the knowledge of people coming out. And I think the answer would be for those who are in training that the curriculum needs to have some time allotted to this. For those who have passed out, I think, and the people like us who are coming to terms with technology, I think conferences like this one, I was listening to a few of your speakers, very excellent and very basic. They would understand. I mean, ours is only one course. I think I saw another question asking for details on this course that we are doing. It's on the AHPI and PHFI websites. But yes, and I think every hospital also does some amount of training. So if they go from hospital A to hospital B, that's taken care of. But yes, this is an important question that you've asked. We need to start taking measures to implement both short-term and long-term solutions right away.
Thank you, Dr. Alex. I think AHA, Academy of Hospital Administration, and PIB together can work on a module where they can talk to the Medical Council of India, Dental Council of India, Nursing Council together to include some type of curriculum in the graduation program itself, because now India is going to go on a digital mode in the healthcare. I think this is a high time that we people get together and try to put in the policy matter at the top level.
Yes, I think the more people put pressure, the government will listen. So it'll be great. We can get together with AHA, we can get together with other organizations. But yes, I agree with you that this is imperative that this be done soon.
Sector, I'm of the opinion that it doesn't matter that, where the candidate goes after training. We must start implementing these programs immediately and do it at every level so that wherever the candidate goes, actually he or she is going to work in the health sector only. It becomes an asset for us. So we need to train them, and it doesn't matter whether he's leaving after the training in the institution or not.
Absolutely, I agree.
Good afternoon, I'm Dr. Archana Mishra. Dr. Alexander, you have already mentioned about this in your presentation, about empathy aspect in the healthcare. Related to that, I just wanted to seek more clarity because I understand that this is the initiative needed at the government level. However, there is an increasing incidence of violence against healthcare professionals and lot of such concerns. And now we are also talking about digitalization. So what are the, I would say, what are the SOPs or concerns at the administration level we need to enforce to ensure to meet at both these two extreme ends, where we are talking about digitalization and also about empathy? Thank you.
Yeah, see, when I spoke a little earlier about communication, if you look at the situation in India today, yes, there is violence against doctors, there is attacks on medical professionals, there are attacks on hospitals. But if you actually analyze all these incidents, and we have done that, about 70 to 80% of these incidents are because of inadequate communication. And when I talk about inadequate communication, I also talk about I also include empathy and openness. So I think that's very important. We hope that now with the introduction of this in both the undergraduate and postgraduate curriculum, not only in medicine and nursing, it's also in nursing and other allied health. I think the future generations, this will be and also a module on ethics, which also covers transparency, etc. So I think the future generations will be well prepared for it. What we have done is, for those who do not have the advantage of listening to these, having been in the course, we have actually had nationwide communication courses all over the country. And I think each hospital has to train its people into this. And similarly, we need to take the same way forward with technology and technology awareness. I must also say, I didn't know Prem was going to be here today, but Prem has played a very important part in all the work of AHPI and done by getting policy changes. And we will use his offices also for this as we go forward.
There's a question. What about the implications of AI in hospital administration?
I may not be the best expert to answer that question, but as a hospital administrator, implications of AI. See, again, whatever we do, there has to be a balance. We cannot completely depend on any technology. As I said earlier, my answer would be generic, that we have to ensure that we use AI or technology. It should not become our masters. So it should not be out of control. Always the human element is far more important than anything else. And when we deal with our colleagues, our juniors, other people in administration, human relations are important, empathy is important, trust is important, and modalities like artificial intelligence, etc., should only be used to facilitate that.
That is very true. As even WHO says, it is high tech with high touch.
Yes, absolutely.
So both the things have to go hand in hand.
Hand in hand, yes.
Yeah, and you have very, sort of importantly highlighted that in your talk also. So that's very true. Any other questions? Thank you very much, Dr. Elizabeth. That was a wonderful presentation, and it was a pleasure chairing it with Dr. Prem. And since he's there on the site, I would leave the last words with him. And anything that you would like to say, I have, really appreciated the presentation and the insights that he has given. Thank you so much.
Alex, it was a wonderful presentation as always. You've always been very proactive in these presentations, and you've a lot of wonderful ideas that you have implemented over the years. I must congratulate you on taking up the issue of training medical professionals in information technology, which is very, very vital. Thank you, Alex.
Thank you. My pleasure.
Thank you.
Thank you very much, sir, for your valuable information. It will definitely help us in future. Now, on behalf of SASH 2021, we would like to present memento as token of gratitude to our speaker, Dr. Alexander Thomas, and also to our chair, Major General Jagtar Singh. Now, we would like to call Dr. Prathapan Nair, Senior Medical Administrator, Amrita School of Medicine, Kochi, to present the memento to our chair, Dr. Prem Nair.